So today we are continuing yesterday's class. In fact, what was discussed yesterday will be reflected how the students will answer with each case which will be discussed today. Just because it's a continuation of the class, I have a special duty to invite and welcome our senior teacher, Dr. Dhananjay Kumar, who has kindly agreed to be the moderator of today's session. Welcome, Dr. Kumar.
Hello, good morning, Ranjan.
Good morning, good morning. Thank you, Dhananjay, for participating for today's program.
Thank you very
Today,
much for incorporating me.
Because you are a part and parcel of teaching program of EZUSI. So with this small introduction, I would request the today's moderator, our very favorite Dada, Dr. Kallan Kumar Sarkar.
Hello.
To take over, Kallanda, to take over today's class and start it
Yes.
in time so that it can be finished also in time.
So I think the first
Renal cell carcinoma is a very common topic for discussion both in theory and practical, and you will get enough clue how to prepare yourself for the examination. Over to Dr. Sarkar, sir. Oh, Kulanda is in his garden today.
Sir, good morning, sir.
No. I got a bit held up with traffic.
Your network is not working well.
I think the moment.
Yeah.
Good morning, sir. Ranjan, sir, good morning.
Good morning, Raj. Welcome.
How are you, sir?
I'm fine. We'll be preparing ourselves to participate in your program in August.
Definitely, sir. You have to come, sir. And apart from this, other students here are also.
I think all students should participate actively in the different operative workshop. That is much more important for them in the learning phase. Yeah. Because now what they will learn, they have to conduct it. Dr. Ranbir Prasad Singh, our president, has joined just now. I will request him to welcome all the faculty and the students so that they can start the program right in time. I think Dr. Kallan Sarkar is having some network issues. That is why he is having problem, but he will join definitely sometime. By this time, I will request Dr. Ranbir Prasad Singh, sir, to welcome the faculty. President, sir.
Ranjan, can you hear me?
Yes. We can hear you.
Yeah, Ranjan, could you please introduce the first speaker and the two students? I'll do that in a moment. It's just my.
I understand. Just a minute. Yeah. Let me take out. Today's first will be a case presentation. The students who will participate in this case presentation are Dr. Jatin Anshuman and Dr. Kunjan Kumar. Teachers, as usual, Dr. Tarun Jindal, Dr. Samir Swain, Dr. Rajkumar Sharma, and Dr. Kanishka Sarkar. Kanishka, welcome in today's program. You have a big role today to teach them about the recent advances in the non-surgical management of the renal cell carcinoma. So, Dr. Jatin Angshuman and Kunyam Kumar, they must introduce themselves when they will be called. And the first case will be a case will be presented by, who will present this case?
Dr. Dhananjay Kumar is going to present the case.
Okay, Dr. Dhananjay Kumar, sir, Dr. Kumar, please present the case, and two students are there, and accordingly, teachers, Dr. Tarun Kumar Jindal and Dr. Somi Swine, or Dr. Tarun, all four of the teachers, faculty can participate in questioning the students. Dr. Kumar, please share your screen and start the case. Dr. Ranbir Prasad Singh.
Yes, good morning.
Sir, please welcome, sir.
Good morning,
welcome
everyone. Sorry, I am 1-2 minutes late. Today is the clinical presentation, and I welcome the moderator, the expert, and all the faculties and students. You are all well versed that clinical cases present is the most important part of your examination, and be very thorough. At least start the case, the first symptom when it appeared. I mean, when first was patient all right, and the progression of the disease. Don't jump on diagnosis in the beginning itself. There are very few spot diagnoses you can make. So it should be thorough history and the clinical examination. That is very important part, and everyone repeats it. While you are examining a case, your complete systemic examination should be there. And then we progress in a systematic manner for the examination of the this investigation, and then the diagnosis. So this, I hope that all are expert and they are all qualified. They will be able to make it and fruitful for you all, and so that you can do better in exam. Please go ahead, sir. Moderators, please.
Dr. Dhananjay Kumar, sir, please share your screen and start today's program.
Good morning, everybody. Thank you, Dr. Day. And thank you also, Dr. Singh. Let me present the case. Who is the other student? Dr. Kunjan is there.
Yes, sir.
And there is
The
Dr.
other student, please name it.
Yes,
Dr. Angshuman.
Yes, sir.
Dr.
Good morning, sir.
Dr. Angshuman.
Yeah. All the students are requested to introduce themselves before the
Yes,
program
please introduce
starts.
yourself. Dr. Kunjan and Dr. Angshuman, please introduce yourself.
Good morning, sir. Myself, Dr. Jatin Anshuman, third year resident in urology at SC Medical College in Cuttack.
Thank you. And
Good morning, sir.
Dr. Kunjan.
Sir, I am Dr. Kunjan Kumar. I am a third year MCH urology resident in RCC Medical College, Kolkata.
Thank you. So you are welcome for the first case. The very early morning. Hey, July. Okay. So this is the first slide. Dr. Angshuman and Dr. Kunjan.
Yes, sir.
63 years old gentleman came to our OPD with complaints of pain in the lower abdomen since last 10 days. Pain is dull aching, not radiating anywhere, and insidious is onset. History of constipation present, no history of fever. Mark these symptoms very well. No history of fever, weight loss, anorexia, jaundice, bone pain, respiratory distress.
Yes, sir.
He has history of hypertension, and that is on oral medication. It is controlled. Family history insignificant. So this is the history, and from the history, as Dr. Ranveer Singh right now said that history is very important, and you have to take all points judiciously, where this fever, weight loss, anorexia, jaundice, bone pain, and respiratory distress, why these symptoms are particularly stressed upon. You please answer.
Sir, fever, weight loss, anorexia, all of these are commonly symptoms that we ask for when we are asking about metastatic malignancy or locally advanced or metastatic malignancy.
Locally advanced and metastatic malignancy.
Yes, sir.
So there are some disciplines to be involved by these symptoms, and particularly, this pyrexia of unknown origin, that is sometimes the main symptoms with which the patient presents to us in the OPD, pyrexia of unknown origin, and moves from OPD to OPD, and ultimately diagnosed that he has been suffering from. Okay. So next slide. On examination, this is also very important. After history, thorough examination of the patient is of utmost importance. Patient is conscious, alert, and oriented. ECOG 0, BMI 24.7, all are important. Pallor plus, no icterus, clubbing, cyanosis, lymphadenopathy, pedal edema. Abdominal examination reveals normal shape and contour with centrally placed inverted umbilicus. All quadrants are moving equally with respiration. Hernial pieces are normal. Genitalia normal. On palpation, abdomen soft, non-tender, no lump palpable, no guarding, rigidity, or distension. No history of free fluid in the abdomen. On examination, there is no free fluid in the abdomen. Bowel sounds heard and are of normal. Other systems within normal limits. So, at this juncture, would you like to add anything, or would you like to answer me something I will ask you? Would you like to add anything in this examination process?
Sir, Pallor is present, sir. So,
So the digital rectal examination has not been performed. That is one thing that is missing here.
yes.
Previous slide. Previous slide. Hello? Can you hear me?
Yes.
Yes, sir.
So you want to add digital rectal examination?
So we also don't have any history of whether the patient has lower urinary tract symptoms or not, which is important in a
Only
patient
lower
who is
abdominal pain. he has history of lower abdominal pain.
So, if there
history
is any
of
past
lower
history of
abdominal
surgery or not?
Sir, any
history of
renal angle
target
tenderness or fullness?
No, there is no tenderness or fullness, any quadrant. That abdominal examination already specified.
Yes, sir. No, sir. Specifically about renal angle knee fullness.
Renal angle tenderness
Yes,
or
sir.
renal
Fullness or
angle
tenderness.
fullness.
Yes, sir.
And DRE examination, DRE examination, what will you find? What do you expect?
So, there may be an enlarged prostate, but otherwise,
Next. তুই এখানে বুঝতো। What do you expect? DRE examination?
so the prostate may be enlarged, but otherwise, a DRE is unlikely to be remarkable.
Yeah. So at this juncture, what do you think? From the history and the physical examination? Please sum up.
Sir, basically, this patient is a 63-year-old known hypertensive, sir, and the positive, no other positive findings are there. There is pallor is there till now. The rest, everything is normal. So there is no tenderness, anything is there. So,
So you didn't have any clue right now. Okay.
So there is mild pallor, so the patient may be
specify.
having an element of non-visible hematuria. Otherwise, there is nothing
Yes, sir.
remarkable.
No, there is no such. There is no such.
Microscopic hematuria.
Yes.
Yeah. So this is the blood parameters. CBC hemoglobin 13.4 gram%, WBC 8,600, platelet 1.2 lakhs per cubic millimeter, sodium 145 milliequivalent per liter, potassium 4.30 milliequivalent per liter, urea 26 milligram per dl, creatinine 1 milligram per dl, FBS 96 milligram per dl, PPBS 112 milligram per dl. LFT, liver function test within normal limit, serum calcium 8.8 milligram per dl, LDH 236 per liter, ESR 18 millimeter per hour. So anything from these blood parameters? Any clue or any omission here that you want to add upon?
No, sir.
Not right now.
No, sir.
So I'll move to the next slide.
Yes.
Yes.
This is the urine routine microscopy examination. Color watery, transparency clear, specificity 1010, reaction acidic, sugar, phosphate, acetone, occult blood, bile pigments, nil. Pus cells 0 to 1 per high power field, epithelial cells 0 to 1 per high power field, RBC 2 to 3 per high power field. Dust, crystals, yeast, others nil. So, is there any clue here?
Sir,
No,
53 years old male with dull aching pain, lower abdomen, right lower abdomen. Nothing in the physical examinations relevant. Urine routine analysis shows RBC 2 to 3 per high power field. No pus cells. So, what do you think right now?
Sir, there's
Sir,
nothing very.
no, it is still normal, sir. RBC is also acceptable range.
RBC 2 to 3 normal.
Yes.
So normally we would be we would consider 2 to 3 RBC is normal. However, because this patient has mild pallor, that is the only clue. Otherwise, we don't have anything significant until now.
Okay. So move to the next slide. Today.
Yes, sir.
So this is the USG abdomen and pelvis. Kunjan?
Yes, sir.
There is an ill-defined spherical endophytic hypervascular mass lesion noted in right kidney. Categorically, ill-defined spherical endophytic hypervascular mass lesion noted in right kidney, measuring 4.5 by 4.3 millimeter. Case is prominent on right side. Left kidney normal, bilateral ureters normal in course and caliber, mild thickened bladder oval, changes of cystitis. Residual urine, prostate 38 cc. So what do you think?
Sir, the ultrasound suggests that this is a renal mass which is endophytic, and it is clinically it is TNM T1B, sir. It is 45 into 43 mm.
T1B.
And PCS is sir. The T1A is up to 4 cm, then 4 to 7 cm is T1B. So it falls into T1B stage. And also PCS is prominent on the right side. So this can be a transitional cell carcinoma. I mean, involvement of the can be a TCC or
transitional cell carcinoma.
So
there is an ill-defined spherical hypervascular endophytic mass lesion. In the right,
ill-defined is not exactly a characteristic of TCC, sir. TCC are
sir, considering the patient's age, considering the patient's age and symptoms and these findings on ultrasound, I would my first diagnosis would be renal cell carcinoma of the right kidney.
So Kunjan is with the RCC.
Yes, sir. The patient is 63 years old. PCC is older.
PCC. Yotin,
no, sir. Actually, my first diagnosis is also RCC, but my second diagnosis will be TCC. Yes. Based on only the finding that PCS is prominent, but primary diagnosis is RCC.
Yes. Then what will you order for next?
Sir, we can go for a multiphasic CT of the abdomen with multiphasic CT of the abdomen, triphasic CT of the abdomen.
Right. Move on to the next slide. Okay. This is non-contrast CT abdomen and pelvis. So read it carefully.
So these are axial images of a non-contrast CT of the abdomen at the level of bilateral kidneys in the lower pole of the liver. The left kidney appears to be normal. Parenchyma is appears to be parenchymal thickness appears to be normal. On the right side, there appears to be a hypoattenuating mass, mostly endophytic. So we would need contrast images for any further characterizations.
Okay. And Yotin?
Yes, sir.
You?
Yes, sir. Sir, this is
you want to change your diagnosis at this stage, or you want to stay with TCC?
Sir, RCC, sir. My first diagnosis will be RCC only. My second diagnosis is TCC.
You are still
no,
with,
sir,
you are still with TCC.
No, RCC, sir. First diagnosis will be RCC.
Okay, so you want to have next contrast, okay?
Yes, sir.
Contrast. Yes.
Acha. I'll request the other teachers to intervene at this juncture. Please ask the students if you want to ask anything, sir. Hello.
Hi, hello, sir. Good morning.
Good
I'm
morning.
Dr. Vijay. I'm Dr. Vijay.
No,
I would like to.
Dr. Vijay, good morning. Very
Yeah, good morning, sir. Just, do you think any other probability apart from RCC? RCC is probably the most preferred diagnosis in this scenario. Can you think of anything else?
Yotin and Kundan, you answer, please.
Sir, it may be a benign lesion.
What?
It may be an oncocytoma.
But that could be, that has to be a mass. That is a mass. That has to
That
be
is a mass.
clarified.
Yes.
Anything about, have you heard the entity of hypertrophic column of botany?
Yes,
Yes.
sir. But yes, sir. But with this image,
sir.
the image that we have seen in the non-contrast image, it's less likely
It
to
is
be a
unlikely,
hypertrophic column.
unlikely. So
Yes,
is PCC is very unlikely from the presentation and the CT finding, but still you are discussing it.
Yes, sir.
Then move ahead with the contrast, no doubt. Take care.
Okay.
Next will be contrast enhanced.
Yes.
Can I ask a question?
Yeah.
Yes, my question to the students are that before you order a contrast CT, what are the considerations you have before you advise contrast CT for a 65-year-old patient with a suspected renal tumor?
Yes, sir. So we should make sure the patient is well hydrated, sir. And first we have to rule out any normal kidney function test is there, and patient is well hydrated, and there is no history of any contrast allergies in the past or hello.
Yes, carry on. Carry on. So, how do you assess renal function?
Sir, by the serum urea creatinine, as it has been already done, sir, it is within the normal range, and we will also assess for the hydration status of the patient by checking the tongue is moist or not, or and and we also ask about we can also take history of any allergies in the past.
In this case, with an otherwise healthy 63-year-old patient with well-controlled hypertension and serum creatinine of 1, we don't further evaluation at this point is not needed, sir. We can proceed for contrast analysis. Yes.
Okay, and what sort of a CT examination will you request?
Triphysics.
Sorry?
Sir, triphasic CT with comment on the enhancement of the mass.
Okay, with the renal protocol. Okay.
Renal protocol, yes.
Renal
CTKU, CTKU.
Okay.
Yes.
Carry on.
Sir.
Oh, I see. So, no. So, Professor Kumar, you had asked a question here. So this is a contrast CT scan. So can you describe it?
So this is the axial section of the contrast abdomen pelvis CT, with showing the axial section through the at the hilum of the bilateral kidneys, sir. So the left kidney is in the nephrogram phase. Right kidney, sir, there is you can see a well-defined mass of around as it has been already said in ultrasound 4 into 4 cm, occupying the so this is a mid-polar region, sir, because we are seeing at the hilum
So this mostly involves the mass involves the middle pole of the kidney, and it also occupies some part of the pelvis. It's bulging into the pelvis, and also it is well marginated, sir. So probably a pseudo capsule can also be delineated from. And there is no vascular.
So from what we can see here, the renal vein and IVC appear to be free of any tumor thrombus, and there appears to be a small calcification which may be at the periphery of the lesion, or it may be a small calculus in the pelvic calyceal system. Left kidney appears to be normal.
There is a small cyst in the left kidney.
And yes, sir, a small cyst in the left kidney, likely Bosniak 1.
Another thing in differential diagnosis, you may mention about any secondary from other primary sources. Secondary tumor in the primary from any other primary sources. And the other thing, even in non-contrast CT, you may say that impending or developing renal abscess. Sometimes if the patient has got fever and all these things. But definitely the secondary deposit from other primary sources will come. The column of Bartin against the point is that column of Bartin, the nephrogram or the parenchymal density is almost the same as the normal parenchyma. Not like this in even in non-contrast CT. So column of Bartin will not come. Okay, proceed please. Thank you. Sorry.
On the basis of the CT scan, can you make a provisional diagnosis of the image that you've seen?
I would stick with my earlier diagnosis, sir. A mass in the right kidney, which appears to be enhancing as intensely as the normal renal parenchyma, most likely to be a renal cell carcinoma, most likely to be a clear cell renal cell carcinoma.
So what are the characteristics of a renal cell carcinoma that you see on CT scan? Apart from enhancement, are there any other features on this CT scan which point towards this being a renal cell carcinoma?
Sir, the normal architecture of the kidney has been lost. It appears to be heterogeneously enhancing. There may be small areas of necrosis within the tumor. The renal contour has also been lost, not lost, has been distorted. Let's say, and
okay. So
one thing I would like, Dr. Sarkar, I would just like to interrupt.
Yes.
How you could make the histological diagnosis of clear cell carcinoma at this stage?
Sir, I'm not making it. Sir, in the most likely.
But you are inviting trouble for yourself if you go on saying like this in the examination.
Yes, sir.
So it's better to be non-committal, speak only what you are seeing and not adding to it, which is not warranted.
Yes.
Okay, thank you.
So Dr. Kumar, are there any other images on the CT scans to show?
Yeah.
Can you describe the CT scan?
See, Jyotin,
Yes, sir.
please describe.
So this is the
This is the coronal
coronal
view.
image, sir, showing the kidneys in their corticomedullary phase, both the kidneys. Left kidney is normal. There can be a small, simple cyst in the upper pole, sir, the left kidney. And on the right kidney, we can clearly see irregular mass. It is involving the middle pole mostly, and slightly the upper and lower pole, and bulging into the pelvic system. It is heterogeneously enhancing, and the enhancement slightly less than the parenchyma. You can clearly describe this, but and rest everything is normal. The size of the mass will be around
5 centimeters.
4 into 5 cm. 4 into 5 cm.
Yes.
Around 4 into 5. Yes,
Just one thing, how do you estimate the size on a CT plate?
So we can compare with the adjacent vertebra. If you take the vertebral size to be around 2.5 to 3 cm, then we can make a rough estimation of the size.
Any other thing apart from comparing with the vertebra?
Sir, generally, the most important part is that we have to know if the size, we can compare it with the kidney size, sir.
Yes.
If the general size of the kidney will be around 9 to 10 cm. So if it is involving half of the kidney, so it will be around 5 cm. 4.5.
Okay, thank you.
Yes, sir.
So we discussed yesterday about nephrometry scores.
Yeah.
So, can you apply this? How do you apply it to this particular case?
Sir, the radius of the mass, the R parameter appears to be around 4 to 5 centimeters. So that will give it an R score of 2. It is almost entirely endophytic. So that will give us an E score of 3. It appears to be very closely opposed to the collecting system. So that the E score will, the N score will also be 3. I cannot assign an anterior or posterior score because it is entirely infiltrative. So that becomes X. And the location, it is occupying the entire interpolar region between the two polar lines. So that will also be 3, which gives it a score of 11x. The renal score will be 11x.
Yes.
So what you're trying to say, it's a very complex tumor.
Complex tumor. Yes.
So how do you assess the, how do you define the upper pole, the lower pole on this coronal scan?
So the point at which the renal parenchyma gives way to the dark sinus fat, that is the upper polar line. And again, when we are coming down, where the sinus fat gives way to the lower of the parenchyma, that is the lower polar line. So a tumor that is entirely above that, or below the upper, above the upper or below the lower polar line, will get a score of 1. If it is partially between the two, it will get a score of 2, and if it is almost entirely between the two lines, it will get a score of 3.
Do you think the coronal view that you are seeing gives you a very accurate estimate of the lie of the kidney?
Not this one, sir.
So how can you improve the renal score?
Sir. So can you please repeat the question, sir?
Please repeat the questions.
So please repeat the question.
I think there is a network problem from his side.
Dr. Kalyan Sakha, sir. Hello. Hello. I think there is some problem with the
Network problem is that. Vijay Kumar sir, please continue with
Yeah.
this question.
I just one non-neurological question I would like to ask.
Yes.
Professor Kumar is also there. You describe what do you describe as a pole? It is just a grammatical question rather literal question. Pole, what does it mean?
So
On the earth we have two poles, north pole, south pole.
Yes, sir.
But in kidney we frequently use, most of us use, the radiologist use, everyone uses mid pole of the kidney. What is mid pole? Is it grammatically correct?
No, sir.
What's your opinion, Professor Kumar?
Yeah, you are very much correct. Pole is assigned in relation to the pelvic fat and the calyceal system, the line of interpolar line or intercalyceal line.
So I think we should, the habit of describing it as a mid-polar tumor is something not very grammatically correct.
So
But we are
interpolar
carrying
might
it.
be a better descriptor.
Yeah, that's a better description.
Yes.
Anyway, move ahead. What next?
So
Any other information or it is over? Kunjan?
Sir,
Yes, sir.
Would you like to have any other investigation to add up for your clinical diagnosis or planning your treatment?
sir, I would like to go for a metastatic workup, sir.
What?
So I would like an HRCT of the chest.
Want just plain CT chest? Will X-ray chest want to do?
Sir, in our institution and the recommendation is that in tumors which are T1B and above, CT thorax should be done. In this case, because the tumor seems to be abutting the pelvic calyceal system, that makes it it may be a stage T3A tumor. In which case, I would like to go for a CT chest.
Okay, justified. And what other metabolic workers would you like to have?
So liver function tests have already been done and they are normal. So no other metastatic workup is needed.
The CT angio, we can go for CT angios.
Then what's your plan? What you will advise to the
So considering the complexity of the tumor, I would like to go for a radical nephrectomy.
Still, you will like to go for a renal arteriogram?
Sir, yes, sir.
Even for radical?
Sir, yes, sir. To make sure if there is involvement of the tumor beyond the renal vein ostium. just before going on with the procedure, I would like to make sure that there is no involvement in IV. So it is not very clear.
That you can clearly visualize even on a CECT.
Yes.
If it is properly done and all phases are taken, then you can have a clear outline of the renal vein, the IVC, roughly at the level of the renal vein.
Yes.
You have to think for the cost factor also.
Yes.
Even with the primary CT, if you could get a plate or you get a reconstructed image from the previous plate also, it can be done.
Yes.
If the slices are on the monitor, you can ask your radiologist colleague to provide you with the arteriogram.
It might be.
So instead of adding to the other investigation, I think we should try to minimize it.
Yes.
Yes.
Our president, Dr. Ranveer Prasad Singh, has a question to you, and maybe you can answer him directly. The blood supply by the named arteries. Would you rephrase your question, Dr. Singh? Hello. Hello. Dr. Ranveer Prasad Singh.
There is severe network problem, network issues taking place.
Okay.
Today.
So anyway, one of his questions is the role of renal biopsy. Is there any indication to biopsy this tumor?
No, sir.
No, sir.
Why not?
So this appears to be a malignant tumor in a 63-year-old man with my diagnosis is likely renal cell carcinoma. Renal mass biopsy is not going to change the management in this case at all. So I don't think there is any indication for renal mass biopsies.
So what are the percentages of renal tumors below the size of 3 centimeter, which are malignant and which are benign? Can you tell me?
So, so 20 to 40% tumors may be benign in less than 2 centimeters.
Okay. Okay. So tell me, so what are your indications for renal mass biopsy and how would you do it?
So actually, renal mass biopsy, sir, we have to if we are planning for active surveillance or it is a small mass, less than 3 cm, and we are planning for active surveillance if the patient is also not unfit for surgery, and the patient has CKD. We are planning for nephron sparing surgery. There we can go for biopsy, sir. And also, if there is multiple lymphadenopathies there, we are suspecting lymphoma, sir, or metastasis from there is another primary is there, sir, elsewhere, and along with that, this mass we have found. So if you are suspecting metastasis in that case, we can go for biopsy, sir. And apart from that, if patient is having EZUSI score of 0 and all other parameters normal, we can go directly with the surgery.
Yes.
So, Dr. Kumar, would you take this forwards, please?
Yeah. So this is non-contact.
Okay, but there is one question before we proceed. Dr. Samir Swine has asked actually what sort of a biopsy? I'd also asked, but what sort of renal biopsy would you do?
So image guided. So in this case, we would not do a biopsy. But
okay,
if
no,
a biopsy
not in this case. If you do a biopsy.
So an imaging guided core biopsy, sir.
Okay.
Ultrasound or CT guided core biopsy from a representative area. That is, we would like to go to a solid part of the tumor and get a good biopsy from it.
Kunjan, May I
Sir.
ask you one thing? Would you add along with core biopsy the FNA?
No, sir.
Will not add. Will not go for FNA along with.
Sir, a core biopsy will give us.
Certainly,
Yes, sir.
I appreciate, but along with FNA is much more beneficial because of you will get the cytology and typical patterns of it. The cytological nature will get extra. Okay. So this is non-plasticity of the abdomen and pelvis.
No.
Should I move to other slide?
Please
Yes.
do. I think we're also running out of time because we've got the next case coming up.
Okay. So this is CCT abdomen and pelvis.
So next slide.
Anything to be looked upon in the pelvis?
No.
None.
Sir, the mass appears to be very closely abutting the renal pelvis. Otherwise, there's no more information to be gained here, sir. I would like to see the CT report, sir.
So finally, about mass, it is in the mid pole.
Interpolar region of the right.
Endophytic, strictly
Yes.
endophytic.
Yes, sir.
Vascular.
Yes,
and
sir.
near to the pelvis.
Yes, sir.
Okay. Next. There is nothing wrong in the urinary bladder.
So there seems to be diffuse
There is
symmetric
no
thickening of the
lymphatic.
bladder, but otherwise nothing.
Okay. Next. So this is the CT finding as it is described. There is a presence of partially exophytic hypervascular lesion measuring 4.2, 4.1 and 4 millimeter seen arising mid-polar and lower polar region of right kidney. Pre-contrast, Hounsfield unit plus 22, arterial phase plus 87, portal venous phase plus 60, and delayed phase HU plus 44. Just note down this point, pre-contrast HU plus 22 and arterial phase plus 87 HU. Non-enhancing hypodense areas and foci of calcification are seen in it. The lesion is seen extending up to the renal pelvis. Washout is seen on delayed phase. Few tiny cortical cysts are seen at lower polar. The right kidney is normal size and shape, attenuation and post-contrast enhancement. Cortical thickness is normal, excretion of contrast prompt and complete. Renal vein and IVC appears normal. There is no thrombus. So, what is your idea from this unit, pre-contrast and post-contrast?
So there on contrast administration, there is an enhancement of 65 HU, which gives us it's likely to be a malignant renal mass, likely RCC.
Right.
Yes.
So next slide. So now the plan. What is your plan?
Radical nephrectomy.
How will you proceed? Radical or partial?
Radical nephrectomy.
Justify, please.
Sir, as it was already mentioned on the renal scoring that this is a complex tumor and also it is completely endophytic and it is bulging into the parenchyma.
Pelvis.
So all these factors favors more in points more in favor of radical nephrectomy. Partial nephrectomy, it will be difficult to get the margin, positive margin. Also,
By preserving parenchyma.
Yes, sir. So it is the radical nephrectomy is that.
Would not be a situation when the tumor less than 4 centimeter, absolutely endophytic, centrally located. This partial nephrectomy is possible or not?
So partial nephrectomy is possible, but in a tumor of this size, sir, technically it's extremely challenging, sir. Preserving sufficient renal parenchyma to justify taking the risk of doing the partial nephrectomy, I think, sir, it will not be justified.
There may be difficulty.
Yes, sir.
In the
Bomb
process
ischemia
of
time may be
surgery.
prolonged.
Yeah, and you need expertise. And how do you counsel the patient and the patient party?
So we'll explain to the patient.
You'll be going for radical nephrectomy. How will you counsel the patient and the patient party?
Sir, first we will
What will be your points to make
Yes.
them understand that in this particular setting, radical nephrectomy would be justified rather than partial nephrectomy?
Yes, sir. Sir, first, most important factor is that we have to get the consent of the patient and their attendants. So we will explain the situation to the attendant, sir, that the tumor is the staging of the tumor. We can explain the T1B, and also the tumor is entirely inside the kidney. So it will we have option of partial nephrectomy where we can go for partial nephrectomy in case the tumor was exophytic. It was outside the kidney. But in this case, as it is entirely endophytic, so it will be a difficult procedure, and also to achieve completely tumor oncological negative margins, it is better to go for the removal of the entire kidney. Because if we try for partial nephrectomy, so already the tumor is involving the entire kidney, almost entire of the kidney. So we will not be able to achieve a negative margin in that case, and maybe some tumor with we can have recurrence. So it is better to go for one surgery and remove the entire kidney.
So also the fact that the contralateral kidney is normal, so we can offer the
Yeah,
patient good
yes.
renal function post-operatively. So there is no need to take the risk for partial, and we should proceed with radical nephrectomy.
Yes.
Tell me, what are the unexpected complications you can face during a laparoscopic radical nephrectomy on this patient in a right-sided tumor?
So there may be.
And how would you handle these complications?
So there may be an undiagnosed thrombus in the renal vein. We find that after clipping the artery, the vein is not collapsing, and in that case, we may have to convert the case from laparoscopic to open nephrectomy and do a proper tumor thrombectomy, IVC thrombectomy.
So what is the commonest cause of conversion in this sort of a situation? Is it a palpable thrombus or is it something else?
Bleeding.
Yes. Yes.
Bleeding, sir.
So what are the areas which bleed during a laparoscopic? What are the trouble spots in laparoscopic radical nephrectomy? On the right side.
On the right side.
Bleeding from the lumbar.
Sir,
It is a hypervascular tumor, so there is more collaterals. So mostly lumbar.
It's the same as in open surgery. What are the sites of sudden and unexpected bleeding on a right-sided radical nephrectomy? It may be the same as for laparoscopy or open surgery.
So the gonadal vein may be avulsed from the IVC or may get torn
That's
and
number
start
one.
bleeding.
Very good. That is number one. Number two. It's not a difficult question. Come on.
Adrenal veins.
Anomalies of the renal vein, and number three, adrenal vein.
Lumbar vein.
I'm not asking any difficult questions. It's a very simple question. Okay, so gonadal vein, anomalies of the renal vein, or the anomalies at the level of the renal pedicle, and adrenal vein.
Yes.
So, in an open surgery, how would you, suddenly faced with a gush of blood after removal of the kidney or dissecting in the hilar area, how would you manage it? How would you manage sudden gush of blood during hilar dissection in a right-sided renal tumor?
So we have not completed hilar dissection yet.
We are doing it. Suddenly, if you're trying to say you're doing open surgery and you're trying to dissect the hilum, dissect the renal artery and the vein, and there's unexpected bleeding. How would you manage it?
So we will try to we'll pack area. We'll try to mobilize the upper and lower pole of the kidney, and will so that the hilum can be approached from both sides, and then we'll try to put in a clamp.
What sort of clamp?
A Satinsky clamp. A Satinsky clamp.
So you're
we'll put in a Satinsky clamp. We'll try to remove the kidney, and then once we have taken the mass out, then we'll try to then we'll attempt hemostasis. We'll see if there has been any injury to the IVC or the pedicle, and accordingly, if they need to, we'll have to repair the injury.
Okay. Dr. Kumar, do you have anything to add to this?
You have already asked my questions. That
Yes.
is the short right-sided adrenal vein and the spermatic vein. The two areas most important. So
no, if I'm allowed, sorry, ask how they will manage bleeding from the lumbar vein, which has retreated inside this muscle. Suppose that there is lumbar vein is torn, and then how to manage it.
That is more likely.
And there is no vascular clamp. Suppose there is no vascular clamp. So what are the alternative instruments you may pick up in open surgery? Am I audible, or the question is clear?
Yes, yes, you are audible. Come on, students, come on. How do you manage a retracted lumbar vein into a lumbar vein which is retracted into the psoas?
And you don't have any vascular clamp, you have no place to apply the vascular clamp also.
So for the retracted lumbar vein, we'll take an artery forceps, try to see the bleeding point, grab it and twist it, pull it out, sir.
No, artery forceps is not the best instrument. You can pick up Alice tissue forceps, and there are pictures also in some of these old textbooks. You may arrange, suppose, and even if there is a torn inferior vena cava and you don't have the vascular clamp, then you can put a series of Alice tissue forceps in difficult situations. You must know, suppose you are doing the surgery in a place and suddenly you ask for a vascular clamp and there is no vascular clamp. You will have to manage it. One is Alice tissue forceps, and the other is even you can swab holder forceps. You see, even the swab holder, I have seen one of my teachers using it. suppose when there is no available vascular. So these things you must, and remember, finger is the most important hemostat. Just press it in a very difficult situation. Just press it hard and keep yourself cool. Keep the entire team cool and calm. If possible, you can start singing and wait for 5 minutes, 10 minutes. And of course, yeah, as you have said rightly, once the whole tumor is removed, you have much better space and you are in a much better position. Confidently, you can see the bleeding areas and you can confidently apply the clamps on other things. Never apply any hemostat, this artery forceps blindly. Never. Okay, proceed. Sorry.
Okay, I think we should conclude on this case, Dr. Kumar.
Yeah.
Professor Kumar, I think we should conclude on this case, and we should we should go to the next case.
Okay, we are already late.
I think. So shall we move on to the next case then?
Yes, sir.
Okay. I'm sorry, there was a little hassle when I joined, but today we've got only 4 cases actually. The second case is a patient with a renal mass again. Will be presented by Dr. Rajkumar Sharma. He has 40 minutes, and the students involved are Dr. Noori and I think who else is with him? Dr. Nandesh. Please make yourself visible and audible. And may I also request all the students to be visible and audible. There is Dr. Anirban Mukherjee, Dr. Ravikant, Dr. Washim Mullah, and Dr. Narendra Singh Kurmi. Dr. Kurmi, we missed you yesterday evening. But anyway, I'm glad that you've joined today. So, so please make yourself all visible and audible and just identify yourself. So, Dr. Rajkumar Sharma, would you kindly share your presentation and
good morning.
let us all ask questions which have not been discussed in the previous one. We overran a little bit, because and let's ask questions which have not been asked in the.
Definitely, sir. Definitely, I will try to ask the question, new set of questions for the students so that they will be benefited in their exam. So very good morning to all, and I'm going to present a case, and may I know the name of those students who is with me?
Sir, I am Dr. Mohammad Tagdish Noori.
Okay.
3rd year MCH resident, SSKM Hospital.
Okay. Next one. So the other guys is not here.
There should be someone else with you, isn't it?
Yeah, but I think he's not here. So okay, no problem. Any of you can give the answer when I will ask the question.
All the students, make yourself visible and audible, please. I think so, this is interactive, and all of you have a right. I think right to get a chance.
Okay. So I'm starting my case. So a 55-year-old gentleman came with chief complaint of hematuria since 4 months, right flank pain since 3 months. So Dr. Noori,
yes, sir.
This is the presentation. So what comes in your mind when you see a patient like this with hematuria, flank pain?
Sir, my patient with right flank pain with hematuria, my first provisional diagnosis is renal cell carcinoma, renal mass. Sir.
What else?
Sir, second, my diagnosis is that bladder as well, sir.
Okay, bladder as well. But blood, you will hardly get right flank pain, but
due to hydronephrosis, sir, due to invasive bladder carcinoma, sir.
Okay. Next, what?
Third is, sir, renal calculus. Sir.
Right. You are very right. Renal calculus. What else you can think of?
And another, sir, urinary tract infection, sir.
Definitely. Any particular infection that may present with hematuria and pain among the infection? Any particular type of infection that are common in our country?
Sir, in case of pyelonephritis, sir.
Then you may get the history of fever and other associated symptoms. But I am any other student?
GUTB, sir.
Very good.
Yes,
so TB is common in our country and it may present with hematuria and right flank pain. So you have to narrow down your provisional diagnosis, differential diagnosis. Okay. After getting these presenting complaint. So you have to think about tumor. It may be renal tumor, ureteric tumor, or invasive bladder tumor. Then renal stone, that is very common. That one is this GUTV infection part. So these are the common provisional differential diagnosis that you must think of. Now you have to ask the question, leading question, about history of presenting complaint. So the first is hematuria. What you will ask now with your patient?
Sir, I would like to ask, sir, history of fever, dysuria.
Right.
Sir, any patient history of weight loss, anorexia?
No. I am asking about history of presenting complaint. These are two presenting complaint. Hematuria and right flank pain.
Yes.
You get the detail of this hematuria.
The nature of hematuria, sir, it is the clots, amorphous clots, gross hematuria, or sir, the clots, about clots, sir, there is amorphous clots, or sir, other types of clots, sir. It is, and sir, I would like to ask about flank pain, sir. The pain, the nature of pain, sir. Any radiation is there or not, sir? And
okay.
And pain
so,
is subsided with medication, sir.
Okay, so this is the history of presenting illness. Hematuria was intermittent, gross, painless, occasionally associated with passage of clots. Now I will going to ask, what is the significance of gross? What do you mean by gross hematuria?
Gross hematuria, sir, visible hematuria present all the time, sir.
Right. Means it's visible red color urine to the patient. Okay. And what about passage of clots? What is the significance of passage of clots? When that I am passing clot, so what is the significance?
So types of clots is important.
No. I'm not asking types of clot. Clot passage. Why you are asking about clot? Significance of clot.
Sir, significant is gross hematuria. In case of gross hematuria, the time to formation of clots present, sir.
See, when there is a tremendous amount of hematuria, the clot formation is there. So if there is a significant amount of hematuria or bleeding is there, clot formation chances are very high. Yes. So if the patient passes clots, it means hematuria is very huge or it's in very large amount. Okay. Now you are telling about the shape of clots, no?
Yes, sir.
So what are the shapes of clots?
Sir, amorphous types of clots. And sir, serpentiform clots.
Okay, what are the significance of those clots?
If upper tract hematuria is there, sir, so the serpentiform clots, more chance of because the time to get clots inside the ureter, sir. So it long thread-like clots form, sir. In bladder, generally bladder swells at amorphous clot is there, sir.
Yeah, right. But clinically, do you think you can ask your patient which type of clots you are passing? So it has any clinical significance or it's only theoretical? Have you asked in your 3 years residency with any of the patient?
So no, clinic, all theoretical, sir.
So clinically, it's very difficult to ask our patient that it is like a serpentinous or it's amorphous. So theoretically, it's important to know because our teacher will ask this type of question. So good. Now regarding pain was, yes, sir.
Dr. Maha, just one thing I would like to add.
Yes, sir.
The nephrological bleeding, that's the bleeding which occurs through the glomerulus, usually
Yes,
doesn't clot. They don't clot. Bleeding from urological organ from the pelvic calyceal systems are more prone to clotting. So clotting indicates a point of bleeding from the pelvic calyceal system or the urological disease. Nephrological diseases, the bleeding is there, maybe there, but it usually doesn't clot. This is a crude estimation because the while filtration through the GFR, the others are not filtered. The collecting factors are not so. Nephrological bleedings usually doesn't clot. That's
Right.
a clinical old belief which may not stand to, right today.
Yeah, right, sir. So the pain was present in right flank, which was diffuse in nature, intermittent, and relieved on taking medication. So pain, can you elaborate regarding pain? Any of you, Kunjan?
So, diffuse pain, intermittent, relieved on medication, means it's unlikely to be clot colic.
Right.
This is more likely to be pain because of the expansion of the renal capsules.
Right. So you have to rule out other condition also, like differential in stone disease.
Yes.
Okay. So most likely the pain is here intermittent and diffuse. It's not acute pain. So in a stone colic or clot colic, there is acute pain. Okay. No history of fever. Why it is important here?
So any infection is there or not, sir?
Right.
In case, sir, colicky pain, there is vomiting and nausea is there, sir. So to rule out the stone disease.
Yes, so these are important. In pyelonephritic cases, you will get fever. And one also common disease that we are giving in getting in our clinical practice is papillary necrosis in especially diabetic patient.
Yes.
Presenting with fever, colic, as well as other symptoms. Okay, so it's important to have this in history. So past history. There is no significant past surgical history. So Dr. Noori, why I have asked this question to my patient, surgical history?
Any history of surgery, endourological surgery for stones is there? Because
Right.
the recurrent stones are common, sir.
Very good. So stone surgery is there. Is there any history of stone surgery? The probability of recurrence of stone is very high. So you will think on that line also. Again, regarding tumor surgery also. If tumors are recurrent and you may get a familial history of this tumor or recurrent tumor is also common. So you have to ask any surgical history. Now the important past history is the history of pulmonary tuberculosis 12 years back. For that he was treated with ATT. So what comes in your mind now?
Sir, the chief complaint is hematuria and pain, right flank pain.
Right.
GTB is possibility, sir.
Yeah. So you have to think of GUTB also, because there is a definitive history of pulmonary tuberculosis in this patient.
Yes.
Okay. So now you have to, among the 4 differential diagnoses, you will move to rule out tuberculosis and renal cell carcinoma. Now you have narrowed down your this differential diagnosis to disease like tumor as well as tuberculosis. So these histories are important. In personal history, tobacco history is for 12 years, cigarette is smoking for 12 years. So what is the significance of this?
So smoking is risk factor for many malignancy in RCC, 1.9% to 2% risk.
What are the other factors?
Other factor is obesity.
Other history or other factor that is associated with the renal cell carcinoma?
Obesity, sir.
Right.
BMI, sir, and hypertension, sir. Any patient any aromatic hydrocarbon, so history of any.
See, the three conditions that are mentioned in our book, Campbell book, you can remember by HOT, hot.
Yes.
Hypertension, obesity, and tobacco. Okay. So you have to remember these three are associated with, there is a definitive relation with the renal cell carcinoma. Okay.
Yes.
So there is no history of alcohol intake, no history of hypertension, diabetes. Okay. So regarding drug history, nothing significant apart from an ATT that was taken. Family history, no history of malignancy in family. Why family history is important?
Family history in case of 2 to 4% cases of RCC, 4 to 6% cases of RCC are hereditary, associated with many syndromic disease like BHL, tuberous sclerosis, Gordon's disease, Gordon syndrome. So family history is important, sir, to genetic counseling if for genetic counseling for other members and the patient itself.
Dr. Kunjan, can you elaborate little more?
So in patients with history of renal cell carcinoma specifically, in first and second degree relatives, there is 2 to 3 times increased risk for RCC. So apart from the hereditary RCC, this part is also significant. So we need to take family histories.
Right. So it's important to know the family history. So with the presenting complaint, history of presenting complaint, and the history, drug history, family history, and everything, what is your provisional diagnosis now, till now? Have you narrowed down your provisional diagnosis?
Sir, my first provisional diagnosis, is GUTV, sir, till now, sir. And
GUTV.
Differential diagnosis is, sir, renal cell carcinoma. First differential diagnosis,
right.
renal cell carcinoma.
Right. What next? General examination. Now, patient is conscious, cooperative, and well-oriented to time, place, person. His average build, ECOG score 1. BP is normal here with a 130/90s, and the pulse rate is 80. If no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. So why pallor is important?
Sir, in case of if there is history, hematuria is present, so pallor may be there, sir. And RCC, sir, due to sir, paraneoplastic syndrome, anemia is there, sir. So pallor.
Anemia is more common, or polycythemia is more common in paraneoplastic syndrome?
Anemia is more common, sir.
Right. So regarding this edema, last is edema. What is the sense of edema?
Sir, lower limb edema is if IVC thrombus is there. So lower limb edema is there.
Tell me about the right-sided or left-sided tumor. Tell me more.
The right-sided.
Why?
Sir, right. Sir.
Dr. Kunjan?
Sir. Sir, right-sided more likely because
edema and varicocele. These are
the right-sided hydrocele is there. Varicocele is
varicocele.
Edema
So
is
you got confused with varicocele.
Yes, sir.
Don't make it in your exam. Huh?
Yes, sir.
Think of everything. I have twisted the question.
Yes, sir. Yes, sir.
Okay. So coming to next in systemic examination, inspection, abdomen is flat with no visible lump over the right lumbar region, but on palpation, there was lump palpable in the right lumbar region. Lump is non-tender, bimanually palpable and ballotable. What is your thinking about this palpatory finding?
So if bimanually palpable, the ballotable is if mass is bimanually palpable, then ballotability is not there. So.
Okay. Kunjan?
And the sir, one we don't. It has not been mentioned whether what is the texture of the lump. Is it soft, cystic? Is it hard?
It's irregular and hard.
Irregular and hard. So then, in that case, more likely to be a malignant, a mass, a tumor involving the right kidney.
Right. So, what are the other differential diagnoses of mass or lump in the right lumbar region? What other
adrenocortical
directly jump into kidney or other structure or organ can give this finding?
Sir, any GB mass, gallbladder, non-urological like gallbladder mass can be there.
Gallbladder mass is will be in right lumbar or right hypogastric.
Sir, large mass can be
large mass can reach anywhere, but commonly you have to say where is the common finding.
Otherwise, adrenocortical tumor, sir. Adrenocortical tumor, sir.
Adrenal tumor.
Yes, sir. Any sarcoma of peritoneum, retroperitoneum, sir.
Okay. Colon tumor or gut tumor originating from the
hepatic flexure.
Hepatic flexure, yes, sir.
Colon ureter. Okay. Colon. So you have to think everything during examination if you get something. Okay.
Yes.
Now the inguinal and genitalia are normal. Okay. Here normal. Here comes the role of varicocele examination. It's important in RCC. Okay.
Yes.
What you get varicocele? What you will think if you get?
If varicocele present, sir, then chances of IVC thrombus, sir.
Right. IVC thrombus is very high. Okay.
Yes.
So it's important in every case, in every examination, to see the varicocele. In varicocele, what will be the position of patient when you will examine? Supine, you are examining in supine position, abdominal palpation and all that. So, erect position, right. Per rectal examination, normal, other findings are normal. Okay, now what next? Investigation. What investigation you will advise, Dr. Noori?
Sir, I will advise first ultrasonography, sir.
Okay. Right. Patient is also having hematuria.
Yes, sir. Then, and along with, sir, some routine examination also, sir. Urine, routine examination and culture, sir. And some blood investigation like CBC, KFT.
Right.
And after ultrasonography, if there is mass is present, then other routine examination like LFTs, LDH, and others, sir, and along with, sir, other, I would like further investigate.
Okay, so you got this routine urine findings. Okay, your appearance is clear here. pH alkaline 2 to 3%, 20 to 30 RBCs. Albumin trace, no crystal cast, no microorganisms. So what do you think this finding will tell us, or what is the significance you got from this routine examination?
Sir, already gross hematuria is present, sir. Visible hematuria. So no RBC 20 to 30 RBC micro.
So it's gross hematuria is intermittent.
Yes.
Okay. See the
also with microscopic hematuria.
In routine examination here now the appearance is clear. It's not gross. It's not red.
So microscopic hematuria.
At the time of examination of routine examination of urine, patient was not having gross hematuria.
Yes.
Appearance is clear here.
So,
Microscopic
alkaline,
hematuria.
Yeah,
so
microscopic.
alkaline
Yes.
pH and only 2 to 3 pus cells. So any GUTB can mostly be ruled out now, sir, because there is no pyuria, no aciduria. So GUTB is already out.
Yeah, but it's not a sure sign, but you can think of. Okay.
Yes.
Yeah. 20 to 30 RBC. What is the normal RBC in
Less than
routine?
3. Less than 3, sir.
Less than 3 or equals to 3.
3.
2 or less.
Yeah. Less than 3. Okay. Yeah. What is
First,
the significance of albumin, proteinuria? I think.
any albumin, sir, is albumin trace. There is trace albumin, so sir, normal. Sir.
It's normal, but what if, can you get here +1, +2, or +3 protein in urine?
Sir, in end renal, if there is associated end renal disease, end stage renal disease, and proteinuria is present, sir, due to RCC.
Yeah, Vijay sir was telling in a nephrogenic cause of hematuria, then you will hear albumin more in the routine examination. Okay. Now the urine culture, no, urine for malignant cell is negative. How it is significant to you?
Sir, in case of transitional urethral carcinoma is upper tract, so rule out the upper tract transitional carcinoma.
So every transitional cell carcinoma will have a malignant cell in urine?
No, sir.
So which type of TCC will have?
Sir, high risk.
High risk. High grade.
High grade. Sorry, high grade, sir.
High grade. So high grade TCC will have this malignant cell in urine. Okay.
Yes, sir.
So if suppose if there is a patient and who is having upper tract TCC and urine for malignant cell is still negative, so it means that patient is not having this TCC?
No, sir. Having may have, sir.
Yeah, definitely. So it's not 100% specific.
70%,
60 to 70.
70% in high grades and low grade is about 30%.
20-30.
Right. Okay. So the blood investigation, as you told, hemoglobin is 9.6. Already we know patient is having hematuria. Total count is normal. Platelet count is 2.4 lakh. Platelet, why platelet count is important here?
Sir, platelet counts in case of due to sir paraneoplastic syndrome, sir. Platelet count.
No. Have you heard? Have you read paraneoplastic syndrome platelet? Anything? I have not gone through. Yeah, right. Dr. Naresh.
So risk stratification in metastatic CL is the IMDC. So maybe help.
It's a simple thing. If patient is having hematuria, you have routine test in which platelet count is very important. You advise for CBC and get the platelet count. Sometimes we get the patient with low platelet, 60,000, 70,000, he is having hematuria. Not with the RCC, in general. Okay. So it's important. Urine are normal. LFT is normal. Why we are advising LFT in the case of if you suspect a case of RCC? What is the significance of
paraneoplastic Stoffer syndrome, sir? Loud Stoffer syndrome, and also along with alkaline phosphatase in sir.
What is Stoffer syndrome?
So it is non-metastatic hepatic dysfunction due to increased interleukin 6 in case in RCC, sir. In this about 100% increase on alkaline phosphatase. And 67% increase of prothrombin time and 30% increase.
Okay. So what about if you remove the tumor?
About 60 to 70% is decreases, sir.
It resolves.
Yes, it resolves, sir.
It resolved by cell. Okay. So ESR 30. Serum calcium. Again, why serum calcium is important?
Sir, in hypercalcemia is as a paraneoplastic syndrome.
So among these paraneoplastic syndromes, which is the most common you will get? ESR?
ESR. Increase ESR followed by anemia, sir.
Right.
Then calcium hypercalcemia.
So if there is a hypercalcemia, what is the normal range of calcium?
10.2, sir. 10.2.
12.
8.5
to
to
10.2, sir. The maximum limit is 10.2. 8 to 10.
Okay. I remember 9 to 11. For my lab.
8.5 to 10.5.
So before doing surgery, if calcium is raised, what you will do?
Sir, I
This is a case of RCC and there is hypercalcemia.
Sir, I have to medically treat the hypercalcemia with infusion of hydrate the patient,
Right.
and then followed by, sir, we can give, sir, bisphosphonate, sir. 0.5 mg.
Right. Which injection?
Zoledronic acid, sir.
Zoledronic. How much?
0.5, sir.
4 milligrams.
4 mg intravenously, 1 monthly, sir.
Yeah, 4 weekly. It's very simple. 4 mg, 4 weekly.
Yes.
Remember like this. Okay. Okay. Now we have to move next ultrasound. You have advised ultrasound and you right kidney 6.5 into 5.8 centimeter exophytic SOL in the lower pole of right kidney with mild vascularity. So what is the significance of this line? What you got? What is the what picture you see by reading this?
So the exophytic SOL
with mild vascularity.
Mild, sir, it should be written as solid and cystic, solid or cystic, sir, but 6.5 into 5.8 centimeter exophytic SOL.
It's a solid. It's a solid.
So chances of sir, renal mass is as a RCC, sir.
RCC, very good. What about vascularity? Why it is not an abscess?
Sir, if vascularity for abscess, there in abscess, vascularity is no vascularity, sir. And malignancy and it is vascularity.
Yeah, you will say like this: in a tumor RCC, there is a lots of this neovascularization.
Yes.
These tumor are very vascular and mainly in the center of the tumor. That is okay. But in an inflammatory tumor like abscess, you will get the hypervascularity along the rim of the this abscess cavity. Okay. So this is central, and in inflammatory you will get around the
peripheral vascularity.
Peripheral vascularity, right? And the left kidney is normal. It's also important to note the other kidney. What is going on the other kidney?
Yes.
Okay. Urinary bladder normal. So what next investigation you will advise to the patient? You have got ultrasound and the this thing, blood reports and urine reports. Now what are you thinking? You are thinking renal cell carcinoma now or tumor in the kidney. What next investigation you will say? Generally, patient, if you in your private practice, when you will do private practice, a patient will come with ultrasound and routine tests like blood test and all that. Okay. These investigation will be in the hand of your patient. So next investigation you will say to have.
Sir, I would like to advise CT whole contrast, multiphasic contrast, enhanced whole abdomen. Sir, if urea creatinine is normal within normal range, I would like to
advise. It's normal in this case. It's normal. So we will advise multiphasic CT scan whole abdomen or CT urography.
CT whole abdomen with pelvis, sir.
Why not urography? And what is the difference between triphasic this CT scan and urography, CT urography? Triphasic, what do you mean by triphasic? Already a bit of discussed in previous case.
Sir, in triphasic, after non-contrast CT, there is arterial phase, and corticomedullary phase, and nephrogenic phase. and after the delayed phase also.
Right. See, there are 3 phases: arterial phase, venous phase, and delayed phase. Okay.
Yes.
Arterial phase. Why it is important? When you give the dye, after
Yes.
how much time it will reach the kidney?
20 to 30 seconds.
Right, within 20 seconds. Okay. So it's arterial phase. Why it's important to know and what you will get in arterial phase?
So in arterial.
Okay. Right. Nouri, say.
Sir, in arterial phase, in the condition of vessels mainly, sir.
Vessels, okay. Like?
And
you want to know the renal vessel? Vessel, artery and vein, both are there.
Yes, sir.
If you say vessel, artery
renal
and
artery, sir, renal artery. And vein.
Sir, the corticomedullary differentiation is best seen in the in this phase, as well as the characterization of the tumor is best done in corticomedullary phase.
Arterial phase. Yes.
Arterial phase. Yes.
So again, you will also get the number of arteries. If you are planning to have a partial nephrectomy, then you must know the number of arteries and the characteristic of the tumor in this phase. Okay. Now, the venous phase. Generally, the tumor. So this is the CT scan. You go with the CT scan picture. This is picture. This is the coronal section. Anyone say read the picture? Because CT was discussed in the last case, so I will move next. What do the reading of this coronal section? Any of you?
Coronal section of sir, contrast enhanced CT scan, sir.
How will you identify whether it is contrast enhanced or not in a single picture?
So we'll have to see the aorta.
Yeah, you will get in vessel. Okay.
Yes.
You have to compare with non-contrast. Then you will get the enhancement.
Yes.
So here you are getting a large tumor in the lower pole of the. This is the tumor of the right kidney in the lower pole of large tumor. I will read in the next slide. So this is the slide finding. Okay, a large patchily enhancing heterogeneous mass, 7 centimeter into 6.3 to 6 centimeter is seen in lower pole of the right kidney, extending exophytically to the posterior renal space. Medially, it extends up to the level of pelvis of the right kidney. Renal vein and IVC are free of thrombus. Left kidney is normal. Every line is important here. So coming to enhancing heterogeneous mass. Okay, so this is what are the character of this RCC in CT finding?
Enhancement of more than 15 to 20 hospital unit, and heterogeneous mass and necrosis as present, and the contour of kidney is changed, sir, mainly in RCC, and calcification may be there, sir, inside the necrosis.
Right.
Then also see the renal vein IVC, any thrombus is there or not, sir, and any lymphadenopathy is present is or not, sir, and a tumor involving a pelvic glycine system or perinephric space.
Very good. Very good. Yeah, very good. And one added this thing we can add. What do you mean by this washout, early washout? If someone say early washout in
if tumor is hypervascular, sir, the early washout is seen.
So why it happens? Do you know? hypervascular.
Hypervascular.
In this type of tumor, what happens? There is arteriovenous malformation inside the tumor. So the dye will go to the artery and it will go to the capillary. It will bypass and go into the vein. So there is early washout due to hypervascularity as well as AV malformation in this type of tumor. Okay. So there is early washout of contrast from the tumor. Okay. So if suppose renal vein or IVC is having tumor, thrombus. So will you advise some other test?
The CT angio, sir. CT angiography.
CT angiography. If you get the thrombus. Any other guys?
So, sir, MRI and sir, MRI is better than for the IVC thrombus and ball involvement by the thrombus. So MRI is better than.
Right. If you see, according to literature, and if you have a very good CT scan, it can diagnose any type of thrombus, whether it is in renal vein or IVC. But for the better delineation, you may advise MRI. Okay. In MRI, you can get a bland thrombus also, as well as tumor thrombus. So what are the difference between the bland thrombus and tumor thrombus?
Bland thrombus is not enhancing, less enhancement, and the tumor thrombus is enhancing master inside the IVC.
So among these two, what is the significance? When you will operate, when you will do surgery, what comes to your mind? If you have to choose, suppose patient is, you are in emergency situation, anesthetist is saying, make it quick, make it quick. Among these two thrombus, bland thrombus or tumor thrombus, which you will remove and which you may left behind?
So I will remove the tumor thrombus and I'll keep the IVC filter for bland thrombus.
Right. Very good. So you have to remove the tumor thrombus because, and why it is enhancing, can you tell?
So vascular.
Vascularity is there in the tumor thrombus. So you have to remove very carefully this thrombus. Okay. And bland thrombus, it is non-enhancing. It is the hypercoagulable blood. Sir, you want to say anything, sir? Kalyan sir?
No. I just we've just crossed 40 minutes. So
okay. Sir, yeah. So what is your diagnosis? It's a malignant tumor or benign tumor now?
Malignant
tumor. So based on this, you can now say that this is malignant tumor that I am dealing with. Okay. So any role of biopsy already discussed in the last case. So go through it because in your exam, external will ask regarding biopsy. Biopsy is important if you decide to have percutaneous treatment like thermoablative treatment, or your plan is active surveillance. Okay. Or when you are in confusion whether this tumor is infective in origin tumor. So what is the stage here?
So tumor size is 6 centimeters.
7 centimeters.
T1B
right.
and 0M0, sir.
Right. Very good.
So T3A and 0M0.
No, 7 centimeter.
6.9. 6.8.
Pardon?
Sir, there is active hematuria. That means this tumor has invaded the pelvic calyceal system. So it should be T3A.
See, that is a pathological diagnosis. When you are having CT scan, you can't say this is T1A, B, or C. When the pathologist will say that there is an invasion in the pelvic calyceal system, then you may change your T stage.
No, sir, because patient is having gross hematuria. That is why.
Yeah, the probability is very high. Probability is very high. Okay. So external may ask in either way.
Yes.
You have to prepare. And you have to read the mind of your external, what you want to ask. Okay. So regarding stage, how will you manage this case?
So, sir, I would like to first consult the patient about my planning is for radical nephrectomy. Sir, I would like to consult the patient about the procedure. I will do, sir, laparoscopic radical nephrectomies.
What you will do and what can be done, both are different questions.
I will do, sir, open radical.
Yeah, in which you are do, and if your external ask what can be done in this case, then you have to say other option like.
Sir, laparoscopic radical nephrectomy are
right. One laparoscopic radical. Next,
open partial nephrectomy can be done, sir.
Open partial nephrectomy.
7 centimeter tumor, T1 stage.
Yeah. Why not laparoscopic partial nephrectomy?
Yes, sir. Laparoscopic partial is also often robotic partial.
Yeah, it can be done. Experts are doing.
Yes.
Then robotic partial nephrectomy also done.
Yes, sir, yes.
So if external ask you what you will do and what can be done, you have to think like that. Okay, and give answer. So indication of nephron sparing surgery, it's already discussed in the last case, partial nephrectomy. Achha, what is the difference between partial nephrectomy and enucleation? Those
in partial
watched
nephrectomy,
my video last yesterday.
Yes. Sir, in partial nephrectomy, minimum 2 to 3 millimeter sir, margin is necessary, sir.
Okay.
And enucleation only, sir, around the pseudo capsule, sir, and the tumor is.
Right. Very good.
Blunt dissection.
Regarding partial nephrectomy, if you have done partial nephrectomy in this case, what complication you expect? Vascular injury already discussed with Kalyan sir, Karsar, in the right side. So in the left side, what do you think if it's a tumor in the left side? What vascular injury you may get?
Sir, adrenal vein injury, sir.
Right.
And sir, so renal vein, sir, left side renal vein injury.
Lumbar vein.
Lumbar vein.
No, sir, lumbar right side is more.
No, lumbar is also present in left renal vein ka drainage. Tell me the drainage of left renal vein. There are 3 tributaries that join left renal vein.
Gonadal, adrenal,
and
lumbar.
third one?
Lumbar. Yes.
Lumbar. So don't be confused that it's in right or left. Hai, it's left. Okay. So it's very important, and Chakravarti sir has told how to grasp the lumbar vein. And one thing that I want to add, if you don't able to grasp the lumbar vein and there is a retraction inside the muscle, Swas muscle, take a figure of 8 stitch in this Swas muscle. Okay. So adjacent organ injury is there, and post-op leak. A few lines regarding leak. If you have done this partial nephrectomy and the patient comes to you with a urinary leak, what you will do? How will you?
Many days, sir?
Pardon?
So after how many days, sir?
It doesn't matter. After 1 week, say, or after after the post-operative period, patient is in hospital.
First, I will confirm the leaks. I will devise the drain fluid creatinine with also serum creatinine and also urine creatinine, sir. If
why you want to confirm if you have done the partial nephrectomy? What else can come from this?
Sir, lymphatics may come, sir. Lymphatics may be there.
But if lymphatics amount or urine amount will be very different. Okay, the amount, if you're getting a 500 or 300 amount of fluid, then probably this is urine. And lymphatics is more common when you do radical nephrectomy. Okay, so in partial nephrectomy, hardly you injure any lymphatics vessels because you are not doing or cutting dissection near the hilar region. Okay, So in a post-oblique, if you get a urine from the drain, how will you further move?
Sir, if digestenting is not done previously,
Right.
so I will put the digestant, sir, and also put the catheter, sir, to
very good, very good.
Low pressure, and also give the anti-muscarinic, sir.
Right. Okay. Suppose after 3 months has passed and still leakage is there, what you will do?
Plan for PCN. PCN we can do PCN, sir. PCN we can do PCN, sir. If not, sir, then re-explore the patient.
See, already 3 months has passed. There is no rule of PCN here. You have to revise your surgery and you have to go inside and close the rent if you get.
Yes.
Okay. So, one more slide. If you get margin positivity, suppose you have done partial nephrectomy and the margin is positive.
Sir, if margin is status of margin, sir, is focal or global margin positivity?
Tell me the both. Tell me both.
If the focal margin positivity, then I'll wait, sir, and follow the patient. If it's global margin positive with low risk tumor, then I will also follow the patient, sir, with regularly. If the global margin is high risk tumor, I will re-explore the patient, sir, and
what you will do then?
Sir, if sir, I will cut the margin, sir, and not radical nephrectomy, sir.
Radical nephrectomy will be the probably. You can't remove the margin again. Okay. So thank you very much, and all the best for your exams. All these. Thank you, sir.
Thank you very much, Raj, for conducting a very methodical case discussion. I don't think any of us have much to add here. You've touched all the points very nicely. Now, may I, the last two cases are for based on advanced cancer, and Dr. Tarun Jindal will first present a case on metastatic renal cell carcinoma, and along with him is Dr. Kanishka Sarkar, who is our oncology consultant and resource person. This will be followed by a case discussion from Dr. Samit Swain, again on a case of advanced renal cancer. Okay. So, Tarun.
Thank you, sir. Can I request Ruma to please present the slides? Yes. Right. Can we go to the case history? Next slide. Yeah. Who are these students? Can they kindly introduce themselves?
I'm Dr. Ayman Mukherjee, third year DNB in RN Tower Hospital.
The other one, the second person? Dr. Molla, I believe. He's not there.
Yes, sir.
Right.
Yes, sir.
So,
sir, I'm there.
there.
Yes, sir.
Dr. Molla, hi. So
Hello.
the case is, as it is being showed, 40 years old female presented with dull aching pain in the right flank. There was occasional hematuria, sometimes associated with small clots. There was reduced appetite, there was loss of body weight, and there was occasional low back ache. Considering this history, what else would you like to know?
So what's the duration of pain? Like what's the character? How was the onset, acute onset, insidious onset? Any aggravating features are there or not? Is it radiating? And does it get relieved by any medications? And
very good. So the pain is there in the right flank from approximately 2 weeks. The pain is dull aching in character. There is no radiation. It is not associated with any constitutional symptoms like nausea and vomiting. The hematuria is painless. It is associated with some small clots which are serpentine in nature. The appetite loss has been existing from the last 3 months, and the loss of body weight has been significant. Also approximately 15% of the last 3 months. Next slide, please. So the other history is that the patient is a non-diabetic, non-hypertensive lady. There is no relevant family history. Why is the family history important? It has already been discussed. There is no history of graveluria, turbid urine, or tuberculosis. The bowel habits were normal, and she has no addictions. Next slide. So coming to the physical examination, she is of average build, average nutrition, pallor is present, no pedal edema, jaundice, clubbing, and there is no peripheral lymphadenopathy. Any other information would you like to know at this particular juncture? Dr. Molla or Dr. Mukherjee or anybody else, if any other information is required, I'll tender that.
Sir, I would like to do the abdominal examination.
Yeah, we'll come to the abdominal examination. So next slide, please. So parabdominally, the right kidney appears to be there's a big mass in the right hypochondrium. It is bimanually palpable. It is firm. It is non-tender. The movement is restricted. The liver is just palpable and it is not tender. So the spine is normal. The other abdominal examination is normal. On chest auscultation, there are normal breath sounds. Any other information which you would like to know at this particular point of time?
Sir, I would also like to examine the scrotum and the.
It's a female. It's a female.
Oh, sorry. So,
am I correct to commit the mass to be a right renal mass, or at this particular point, I should say that there is a mass in the right hypochondrium? So in the examination, don't commit that this is a right renal mass. You commit that there is a mass in the hypochondrium or the lumbar area extending from here to there, and whether it's bimanually palpable. So there was a confusion about bimanually palpable and ballotable. What is the difference between a mass which is bimanually palpable versus a ballotable mass? Why are renal masses ballotable? Anybody who can take that?
Sir,
because of the only the medial side is affixed. There is a zero trans fat. So medial side.
Kidneys have hilum over which they can be palatable.
Right. So the kidney tends to move over the hilum. So if you can ballot semi-large masses, but if a mass which is bimanually palpable, it is very, very unlikely that it's going to be ballotable. Right. So the next slide, please. Her hemoglobin, these are the investigations. So her hemoglobin is 8.5, the ESR is elevated, 50. The blood sugars and all are normal. Creatinine is 1.2, which is borderline. Bilirubin is 1.2, the enzymes are normal. Electrolytes are normal, calcium is 9. And urine routine examination shows no significant finding. Any relevance? Why is this information important?
The system is not involved, so there is no hematuria.
In the background of hematuria, hemoglobin becomes important. Apart from that, why do you want to know serum calcium? Why do you want to know the bilirubin? Why do you want to know the platelets?
Is there any metastasis in the liver or not? Or
we are still not there. We are still away from the metastatic workup. So at this particular juncture, why are these important investigations important? Anyways, I mean, this has been discussed in the previous slides. So once we come to the subsequent slides, I will reiterate this question to you. Next slide, please. So the next obvious investigation is an ultrasound, which we do, and 12 into 10 centimeter mass involving the right kidney. The left kidney is normal. No other important findings. X-ray chest is normal. Now, how would you proceed? Dr. Molla? How would you proceed?
Sir, I would like to do a contrast enhanced triphasic CT scan of whole abdomen and KVB urography.
All right. So next slide, please. Apart from that, would you like to do any other investigation upfront? So whenever you have big renal masses, I think it's prudent to even go big renal masses I'm talking about. It's prudent to go
chest
for a chest CT scan.
Yes, sir, chest X-ray I will do before going to.
CT. I think it's prudent economically as well as technically to get a Next slide. What are the options of metastatic workup? What metastatic workup you will do, or a staging workup will you do for this particular patient?
CT chest.
CT chest.
CT abdomen and pelvis has been already done. LFT has been done.
Right. Next.
CT we don't do. We generally look for any recurrence.
So in what circumstances will you do an upfront CT brain?
If there is any seizures, neurological deficiency. Any.
Right. So would you like to do a PET CT upfront?
No, sir.
Right. Anyhow, the PET CT has become a fad these days, and the patient came up with a PET CT scan despite he not asking it. So next slide, please. So this is the PET CT scan. Can anybody read the PET CT scan for me? So you have a contrast image, you have a fusion image, and you have coronal and axial images. So can somebody read it?
FPGA is seen in the.
Not that difficult. Anybody can take it.
So
contrast image. So what do you see on a plain contrast CT scan?
So the left kidney appears normal with dilated extraneous pelvis appears, and then the right kidney shows a heterogeneous mass with necrosis feature is present involving a midpolar kidney. Interpolar is involved.
Right. What about the other kidney?
The other kidneys contrast uptake is normal with mild hydronephrosis or pelvic ulcer dilatation is there, sir.
Correct. So what about the nodal status?
There is no significant lymph node enlargement in the hilar region is from this cut section shows.
Right. So now let's move to the PET fusion images. So anyhow, let me just sum up. So there is an uptake in the, so because the mass is predominantly necrotic, the uptake is not as vivid as it should be, but the periphery of the mass is showing enhancement and an uptake on an FDG PET CT scan. Rest of all is normal. Next slide, please. So another finding which was there, that we found that there was an FDG avid lytic lesion in the L2 vertebra with soft tissue component showing epidural extension. So the mass in the kidney along with metastasis in the vertebra with an epidural extension. What is the significance of an epidural extension?
Involving the nerve.
Sorry? What is the significance of an epidural extension of the metastasis? What do we need to warn the patient?
There may be anytime paralysis. He may experience paralysis.
Yes, impending paralysis can happen in these particular patients. So these become a semi-emergency scenarios. Next slide, please. Another lesion was picked up at the level of L4 vertebra. You can see it on the sagittal images. Next slide, please. So another metastasis at the level of L5 vertebra, L4 vertebra, which was seen on the previous scan. Next slide. So to conclude, we have a right-sided renal mass, large renal mass, at least T3 clinically with metastasis to 3 or 4 different areas of bones. How do you manage this particular patient?
First, we have to risk stratify the patient.
Wonderful. So what are the risk stratification models that you are aware of?
So one is MSKCC and another is IMDC.
So what is the current model which you are using?
So
And which is a
MSKCC.
better model?
MSKCC.
Wonderful. So
MSKCC.
what are the
IMDC.
constituents?
You'll see
Sorry?
the performance score, the hemoglobin, the
What is the
calcium.
performance score?
1.
Karnofsky score is less than 80%, then we score it +1.
Right. So what are the other parameters?
So LDH level, when it is more than 1.5 times of normal,
Correct.
and anemia, that is less than the normal level for male or female. And then sir, corrected calcium level, whether it is more than 10 or
What is the corrected calcium level? How do you correct the calcium level? Or what is the other parameter that you need to know to correct the calcium levels?
The serum albumin.
Serum albumin. So there are formulas available online, so you can use them, because unless you know the corrected calcium by the virtue of calculating with the help of serum albumin, the electrolytic calcium will not be truly representative. Other parameters, platelets.
Platelets is in this IMDC.
Yes. So MSKCC does not have platelets, but IMDC has platelets. So IMDC presently is considered to be better as compared to MSKCC. Right. Any other thing?
Sir, diagnosis
One more
of
parameter is
from
remaining.
sir, less than 1 year to systemic treatment, if there's an we score +1.
Correct. Correct. So how do you grade? What are the 3 grades in which you place the patients by the virtue of these stratification criteria?
So it is a good, intermediate, and poor.
Right. So what is the score for a good?
Good is 0.
0.
Intermediate is 1, 2, and poor is more than 3. More than equal to 3. Yes.
Perfect. So we need information to first of all risk stratify. So why does this risk stratification come into being? Why is it important? How does it manage? I mean, how does it alter your management? Supposedly this patient
in
is
low
a
risk, sir. So in low risk, we can
there is nothing like low risk. There is nothing like low risk.
There is survival. We can assess that, like in good risk, the survival is like 220 months around, and in case of poor risk, the survival is around 4 months. So
that is fine. You risk stratify you give the survival statistics, but how does it alter your management?
So in good risk, we can give the patient upfront cytoreductive nephrectomy, but in the intermediate and low risk,
You
we
use
have
the
to
word cytoreductive nephrectomy. What is the difference between a cytoreductive nephrectomy and a palliative nephrectomy?
in cytoreductive nephrectomy, so we'll be trying to remove the tumor as far as much as possible. But
what is a palliative nephrectomy?
The main aim is to relieve the patient's symptoms, the symptomatic relief she should get, like if there's pain or if there's hematuria.
Right. The next slide, please. Next slide. So as it has already been discussed, this is from the EUA. So do not perform a cytoreductive nephrectomy in MSKCC poor risk patients. This is a very, very strong recommendation. So you can still consider a cytoreductive nephrectomy in a person who is a good risk candidate or an intermediate risk candidate. Rest of all are weak recommendations, so I would not get into it. But again, the message is that if the patient is a poor risk, please do not consider a cytoreductive nephrectomy. Next slide. So this is a flow chart, very simple flow chart. So if you are considering a patient for a cytoreductive nephrectomy, if the person is a candidate and if he has oligometastatic disease, what are you supposed to do? So what is an oligometastatic disease? What is a single metastatic disease? Does it matter in cases of renal cell carcinoma?
So if it is single metastasis and in the pulmonary metastasis, it is better to remove the tumor.
Remove the tumor, which tumor? Kidney tumor or the pulmonary tumor?
Pulmonary tumor, sir.
Right. So if you are able to offer a R0 resection to both the primary as well as the single site of MET, you can get away without giving any kind of adjuvant therapy to these patients. So yes, R0 resection, if possible, should be offered. So metastectomy should be offered. What is
Yes.
oligometastatic disease? In kidney, there is no actual definition, but for practical purposes.
If metastasis rate 1 to 2 sites.
Correct. So 1 to 2 non-contiguous sites, if they are involved, so then we consider it as a oligometastatic disease, though the definition has not been, it's not an approved definition as in prostates, but yes, we practically consider if there are 2 non-contiguous sites, we kind of label them as oligometastatic disease. Next slide. So what about local therapy for metastasis? Next slide, please. I think Dr. Kanishko can take over from here.
Thank you, Dr. Tarun. Traditionally, we consider as radiation oncologists, we consider renal cell carcinomas to be radio-resistant tumors. When we use conventional fractionated radiotherapy, so conventional radiotherapy is when we use lower size of the fractions, around 1.8 to 2.2 gray per fractions. But renal cell carcinomas can be very radiosensitive at higher doses which we use in SBRT, which is called stereotactic body radiotherapy, where we use more than 6 gray per fraction. SBRT can be used both for the primary as well as the metastatic sites, and image guidance, proper immobilization of the patient, and motion management, because a kidney tumor can move during respiration, are the keys to successful treatment. And next slide, please. As discussed by Dr. Tarun, we can actually use SBRT in cases of oligometastatic disease. Say, for example, a patient with a primary renal tumor has got a solitary brain mets, or has got a solitary lung mets, or a solitary spine mets. So stereotactic radiotherapy can be a very efficacious treatment for that. And SBRT is also an option.
हाँ, अब 2 बजे आइए, 2 बजे.
So SBRT can also be considered an option in oligoprogression for metastatic RCC patients. Say, for example, the patient is on a TKI, and we do a response assessment scan after 3 months, and we see that the other sites are well controlled, but there is some progression, probably one bony lesion. So SBRT can be considered for that lesion without changing the backbone of the systemic treatment. Next slide, please. However, the point to be noted in mind is that, next slide. Yes. However, in cases of diffusely metastatic disease, SBRT has no role. So in these cases, when the patient has got, say for example, multiple bony sites, we can consider palliative radiotherapy to the painful site for symptom palliation, where various schedules like 20 gray in 5 fractions, or 30 gray in 10 fractions, or 8 to 9 gray single fraction is well enough. Next slide. In this slide, however, we don't have anything about radiotherapy, but about the strong recommendations is that, as Sir had said, that there is no need of adjuvant therapy in such patients after metastectomy, and no evidence of disease. I think I'll take it back to you, Dr. Tarun.
Thank you. So the most important thing which I would like the students to know is that your examiners will certainly ask that if the patient presents with bone pain, what are you supposed to do in this particular patient? So radiation can be offered for symptomatic relief, but not as a curative modality. The other question which the examiners are very fond of asking is, what is the dose of radiation which you will offer to these particular patients? So please remember the simplest thing which is there in the NCCN guidelines, that in a single dose, you can deliver 8 to 9 gray to the affected bony site. Another question which I would again like to reiterate is that SBRT is now being evaluated for the primary tumor control. So please remember that if you are not offering any kind of definitive therapy to these patients, you may offer SBRT to these patients. So remember, the word stereotactic radiation therapy can be useful in local control in these cases. And now there are studies which are coming, as Dr. Kanishko already mentioned. Next slide, please. So coming to the systemic therapies, what kind of systemic therapies would you like to add? Because this patient is basically a metastasis patient with 3 or 4 bony metastasis with a large tumor, with hematuria. So what is the final treatment which you will offer? First of all, maybe a nephrectomy with a palliative or a cytoreductive intent. But now what about systemic therapies?
So immune checkpoint inhibitors we prefer.
What are systemic therapies that you know of?
So immune checkpoint inhibitors, tyrosine kinase inhibitor.
The oldest one. Start with the oldest ones, because this is the full question in your examination.
So this interferon, interleukins, then tyrosine kinase inhibitors, and then immune checkpoint inhibitors.
Any other ones?
mTOR inhibitors.
mTOR inhibitors. Other ones? Bevacizumab is which category drug?
VEGF inhibitors.
VEGF inhibitors. So whenever the exam question comes in, please remember there are 5 or 6 categories of systemic therapies which can be used. Now, what are the common systemic therapies which you will use nowadays?
So immune checkpoint inhibitors, pembrolizumab and axitinib.
So why not the conventional TKIs?
The conventional TKIs having adverse effect. So
what adverse effects are you expecting, and what are the conventional TKIs that you use?
The conventional TKIs are sunitinib and sorafenib.
And the commonly used one? So now we are not using sorafenib, we are using sunitinib to a very lesser extent. Another one which was commonly used? Name starts with P.
Pazopanib.
Pazopanib. So pazopanib is a common drug. So the questions of side effects are very less with pazopanib. So what are the side effects that you used to encounter at the time of TKIs?
Sir, rashes, dermatitis, and foot syndrome, and sir, with sunitinib, hypothyroidism and hypertension.
Correct. So what are the other therapies now available which have shown better results?
This is an immuno checkpoint inhibitor and PD-1 inhibitor.
What is the PD-1? What is the PD-1 gene? What does it do? Any idea?
Sir, it interacts with the T cells.
Antigen present.
It's a DNA enzyme repair gene. So double-stranded DNA repair enzymes are hampered. So just read about this, because this might again, because immunotherapy is coming in big time, and you might have a full exam question on PD-1s. Right. So any test which you do in these patients before you start the PD-L1 inhibitors?
Yes.
Is there a test which can tell you, which can predict that this patient might respond better than the other patient?
Sir, any targeted therapy, we have to do a biopsy from the said tumor.
You do a biopsy from the, anyways, in this particular patient, you're going for a nephrectomy, so you already know what the biopsy is going to be. But you tell me, what blood test or what genetic test do you perform in these patients to predict whether this person is going to have a good response on a PD-L1 inhibitor therapy? Any idea? Anybody in the student group? Okay, so now you have those PD-L1 level testing available, in which if the value of PD-L1 is more than say 5 or 7%, then these patients may respond better to the patients who have a very low expression of a PD-L1 in their tumor genes. So any other medication which you are aware of apart from PD-L1s, which can be used as a salvage therapy if you fail any systemic therapy? Any idea? So the next slide, please. Let me just sum it up for you. Remember a couple of names. So if it's an IMDC favorable risk criteria patient, then you can use nivolumab. You can use a combination of pembro alone or pembro with axitinib. The salvage medication is cabozantinib, which is used if the primary therapies fail. The alternative options in these favorable risk patients can be pazopanib and sunitinib. If it's an intermediate or a poor risk patient, then again, the same modalities can be offered to these patients. it is better that you offer an IO, that is an immunomodulator, as the first line of therapy, but they are very costly. So in India, we are still stuck with pazopanib. The combination of IO or IO TKI is also found to be superior than IO alone or TKI alone. But again, the cost constraints and the escalation of side effects can be there. Next slide. So what if the patient fails an IO or a prior TKI? The obvious answer is that you can shift him to other therapy which has not been utilized in this particular scenario. So if the patient has been treated with IO, you can add bevacizumab or any VEGF targeted therapy or a TKI. But if it has been treated with TKI, you can change to cabozantinib or nivolumab. I think with this, I would end the presentation. Thank you so much.
Thank you.
Sarkar sir is there?
I think he has got some network problem. Dr. Dhanya Kumar sir, can you please continue? Or Dr. Samir Swain, he has joined. Can he continue with this program? He's having some network problem.
We can start the next case.
Yes, please go ahead.
Sir, anybody to present, or I will have to share the screen?
I think you'll have to share this screen.
You can share your screen.
Okay. No, can it be presented from the host? Then it will be easier for me.
So please share your presentation to me.
No, Kalyan sir has sent to me previously, so that's just a minute. Just a minute, sir. So who are the students? Please introduce. Students can introduce themselves. Who will be participating in this case? Hello.
Ruma, who are the students for this case?
Dr. Wasim Molla and Dr. Kurmi.
Wasim Mullah and Kurmi.
Dr. Robikant.
Who are the students now?
Sir, Dr. Robikant and Dr. Anirban Mukherjee.
Dr. Anirban Mukherjee and Dr. Ravikant, are you present?
Yes, sir. Dr.
So introduce yourself. Dr. Samir Swain is asking. He is the teacher now. You just introduce yourself. You are Dr. Ravikant.
Yes, sir. Myself, Dr. Ravikant.
And who is the other candidate? Anirban?
Dr. Anirban Mukherjee.
Yeah. Please introduce yourself.
Sir, Dr. Anirban Mukherjee, third year DNB student from RNTAB Kundapur.
Okay.
So Ravikant and Hemant will be there in this case. Okay. Hello.
Yes, Samir. Yes, Samir. These
Yes.
are the students.
So are you getting my screen?
Yes, sir.
Yes. So that is 35 female with a history of painless hematuria for 3 months without any systemic symptoms, thin build, no palpable abdominal mass, married without any comorbidity, no issues, no history of any medications or allergies. Since already been discussed in detail regarding renal mass, the clinical features and all, almost 3 cases have already been discussed. So would you like to take any questions, or you want to ask anything specific? What has been discussed before, just to avoid them? Anything you want to ask? Ravikant?
Is that hematuria associated with clot, passing of clot, or?
Okay.
Is it initial hematuria, total hematuria, or terminal hematuria?
Passage of clots, yes, there are passage of clots. So basically, you have already these are the symptoms: passage of clot, pain, everything has been discussed in detail, probably in last 3 cases.
Yes, sir.
So is that clear to you, or you just want to add anything?
Sir, at the outset, if the female is very young, so we'll know the family history.
Okay. So what do you think? Your line of treatment or line of examination or any sort of investigation will go as per your initial evaluation. So what do you think at this point of time?
It can be a renal calculus.
Maybe stone disease, malignancy, bladder malignancy. Yes, all those are coming to your mind. Okay.
Yes, sir.
So leaving apart all the provisional diagnoses, what do you want to go for next?
We'll do a routine blood investigations, urine
Why I am
examination.
skipping these points? Because these all the symptoms and all are being discussed in detail before. So I just want to skip all these things to be repeated. So you want to go for any investigation. What are the first investigation you would like to do?
So blood investigation we'll do CBC, urea creatinine, LFT, PT, sir. Then we'll do a routine urine routine.
Same thing has been discussed the class before, that nowadays almost in urology, always better to ask for ultrasound as a clinical extension. So since majority of urological diagnosis is based on ultrasound now, clinical features are very less indicative. So always better to answer that I would like to go for ultrasound and simultaneously other investigations side by side.
Yes, sir.
So these are the investigations. Significant positive findings: hemoglobin is 9.8, ESR is raised, ultrasound showing right renal mass lesion, chest is clear, CT scan and bone scan is to be shown to you. So this is the CT image. There are few slides only. Just read it. Both of you just read it and tell any positive finding in this slide only. What is the CT image? And tell me the positive findings.
This is the actual view of CT scan showing
This is an
the
axial CT scan. Okay.
Yes.
Showing the excretory phase of the.
Okay. Yeah. So tell me.
Showing a mass near the hilum, where the left kidney appears normal, and the right kidney shows a rounded mass present near the hilum.
Yes. Anything else? So this part you are telling a mass, okay?
Yes.
Sir. Yes, sir.
Yes. And what is this?
It is the large associated lymph node.
Yes. Tell me, please be louder, please.
Sir, there is another mass that is heterogeneous, likely to be lymph node in the hilum region, sir.
Now you see the kidney structure is from here to here, okay?
Yes.
This is the mass region, and this is the CCT contrast enhanced image. This part of artery you can easily see that is pushed anteriorly, and apart from the area of kidney, there is another shadow or heterogeneously heterogeneous structure that you see just most overlying the main vessels of the abdomen. That means aorta and IVC. So this is definitely a lymph node, large lymph node. Okay. Any doubt?
Yes.
Okay. So this is a large lymph node. So what do you think? Chest X-ray metastatic workup has been done. There is no definitive metastatic lesion or chest lesion.
So, as this is a case of renal mass with a large large retrocable renal lymph node.
Okay.
They should proceed with the metastatic workup with
Metastatic workup has been done and it's negative. Only there are mass and multiple lymph nodes in paraiotic group.
As we can see, the area border of the kidney and mass is very clear. We will go for the radical nephrectomy along with the, if possible.
First, tell me what is the stage of this? What is the stage? Such big lymph node is coming under what?
So mass is involving the renal sinus. It is T3N1.
N1.
Okay. Okay. What then? What do you plan for this type of case? Because you have already listened regarding localized, locally advanced, and metastatic group of renal cell carcinoma has been discussed. So just tell me,
the question,
isolated.
Samir,
yes,
there
sir.
was a question, I think, in the previous setup, actually, to answer the question, you just ask about staging. Is staging complete with a CT thorax and abdomen in this case? And how do you stage the skeletal system in these cases? So in this day, I think someone quite rightly asked, I think, in these days, should the patient have a bone scan or a PET CT scan to stage the bones?
Okay. So please answer the question what Sir Kalyan sir has asked.
Sir, as the PET CT is not available everywhere, you can go with the bone scan also, sir, for bone involvement and CT chest and abdomen for the systemic involvement. And if there is any feature of the neurological features, then we can go with the consultative.
Many people are now recommending that you can do the FDG PET CT scan even in a renal cell carcinoma. These are not completely in the guidelines, but to stage the skeletal system as well. So you can possibly, this patient does need some imaging of the skeleton, and it could be an isotope bone scan. But I suppose in these days it could also be a FDG PET CT, even though the evidence is not that strong. I mean, it's not level 1 evidence yet. But carry on.
So just tell me, what are the commonest site of metastasis in RCC? Ravikant?
Systemic involvement is there. The lung is the most common site.
Lung is common. Anything?
Lymph node in the paracaval or adrenal gland is also lung, bone, adrenal gland, liver.
So,
local lymph node.
What sir has already told, FDG PET is almost one of the best modalities to know what are the exact site of metastatic lesion, or you can easily categorize the cases to be localized or locally advanced or metastatic. Okay. Apart from that, if that facility is not available, you can go for HRCT thorax, or maybe X-ray chest is not preferable. HRCT is preferable to evaluate a small, even isolated long beds can be easily known. So this case is a locally advanced, means mass is there in the right side, and second is there are multiple lymph nodes in the paraiotic or retrocable area. So what is your plan now? There is no metastatic lesion as per the evaluation. Hemant?
After pre-anesthetic clearance,
plan is to go for surgery or
right radical nephrectomy.
Yes.
We'll opt for surgery, sir. Right radical nephrectomy.
Right radical nephrectomy. Okay. So what is the probability of survival or 5-year survival with this type of cases, or mass renal mass with nodal mets? If you know, just answer. Otherwise, just skip the question.
Don't know, sir.
Not known.
Not known.
So you will go for only a radical nephrectomy, or you will go you can continue with the lymph node dissection also.
Lymph node, we'll remove the palpable which are visible on the CT scan. We'll remove that.
No, it's visible. If actual imaging is
Visible,
showing
yes,
that
sir.
much of node, is obviously it is
Yes, sir.
clinically significantly visible.
Yes.
So what is your plan? Would you like to remove the nodes also?
Yes, remove the lymph nodes also, sir.
So what is the extent of your dissection then? Sorry. What would be your extent of dissection of lymph nodes?
So it's from the
the
crux of diaphragm to the common iliac vein.
So you want to do complete lymph node dissection from the crux of diaphragm to iliac bifurcation.
Common iliac. Yes.
Is that okay? Both of you are agree, or you want to differ?
Yes, sir.
Okay, we'll discuss it later.
Other students can also participate in this kind of a question, because these are very tricky questions quite often asked in the examination. And if they have any other doubt, they should get it cleared now in this option.
So both of you are on the opinion that both of you will continue with the lymph node dissection from the extent what you have told. Okay.
Which is visible, the lymph node which are visible.
The lymph node which is visible.
Not everything, but which is visible, sir.
Okay. That means clinically evident lymph node to be dissected off. Okay.
Yes, yes, sir.
What is the aim? Why you want to remove these flaws? Sorry.
For prognostics, sir.
You will not just to one thing is to stage the disease, and other thing is to, if the large lymph node is imparting any significant obstruction of the nearby major vessels like IBC, and
you usually don't obstruct actually. Usually lymph nodes never obstructed that.
Otherwise, many studies show that lymph node dissection has not improved the survival also.
Just no therapeutic use, but prognostic use, staging purpose, we do lymph node dissection.
Okay, so these are the operative findings. Just see the operative findings. This you can see the large node. Can you appreciate the nodes?
Yes.
Yes.
Yes. So this is the specimen, and these are the nodes that has been removed.
Yes, sir.
Okay.
The question for the students is that what is the operation of right radical nephrectomy, number one. Number two, historically, what is the name of the person who defined this operation and decided on what are the structures to be removed with this operation? So can you tell me the classical operation of right radical nephrectomy for renal cell carcinoma? What was the extent of surgery? First, can anyone tell me the name of the American surgeon who actually published and defined it?
More than
Can you answer that?
Earlier it was removal of the kidney along with aorta and along with the adrenal gland, but and ureter as much as distal as much as possible. But nowadays adrenal gland is removed, say left in situ, and the rest of the kidney along with the aorta and ureter is removed.
Okay, now just to put it in the picture, I think Charles Robson was the surgeon who actually defined this operation. You know, in our textbooks in the 1970s and 80s, early 80s, Bailey and Love would have a list of structures removed at radical nephrectomy, which would he defined it. He is the person who defined the original AJCC staging of renal carcinoma based on his experience with 60 or 70 cases. And he would remove in all cases everything, including the kidney, the perinephric fat, the fascia of Gerota, and the adrenal gland, and the hilar lymph nodes, and the ipsilateral lymph nodes from the crus to the aorta. Then of course later now the situation has evolved to a state that we just do a partial nephrectomy in well-selected cases, because in those days a lot of unnecessary renal tissue was thereby sacrificed in many cases, many early cases of renal cancer, which did not need such radical surgery. So I think this surgery indicates actually, here we've removed the adrenal, we've removed the nodal mass, and the tumor. It's a renal tumor ulcerating into the pelvis,
Yes.
along with the fascia of Gerota and the perinephric fat and everything. So this is probably close to the classical radical nephrectomy originally performed. And what are the indications for removing the adrenal now?
Sir, if there is any contiguous involvement of the adrenal gland, or if there is large upper pole mass, which is where it is not possible to separate the adrenal from the mass.
I think looking at the latest TNM classification and the NCCN guidelines, it seems that you hardly ever submit. What are the indications of removal of the adrenal? We should tell them.
Yes, actually,
there are actually no indications for removal of the adrenal unless it is radiologically or at operation involved by the tumor.
Involved, yes, sir. If it is not involved, it's not required. Even in upper pole mass, and we are doing a partial nephrectomy, there is no need of dissecting the adrenal. We can easily spare the adrenal. Previous, the indication was different. Now it's very clear that if it is not involved or grossly it is encasing near the upper pole, near almost encasing, or maybe contiguously inseparable from the adrenal, then that has to be removed. Otherwise, no need.
Yes.
Should we proceed, sir?
Please proceed. Please.
Yes. So, so this is the histopathology of that operative mass. That is renal cell carcinoma, nodal mass, all are infiltrated, 13 out of 13. Adrenal is free. So what is your plan of management now?
Sir, we can put her on adjuvant therapy with sunitinib, or just follow up with further.
Regular follow-up.
There was one discussion regarding lymph node dissection. I have told you to, we'll discuss it later. Now you see, regarding prognosis, this slide too, there are two points like management and prognosis. There are a lot of studies coming up. What sir has already told. Initially, it was that complete radical nephrectomy along with dissection of the lymph node dissection, extensive lymph node dissection has to be done. But now the concept is to, if there is visible or clinically significant lymph node, just to have a diagnostic advantage, means just pick it up any sort of lymph nodes overlying that. For prognostication means whether it is involved or not. So complete dissection all around is not required. And second is there is no significant or any clinical advancement or clinical advantage of dissecting the lymph nodes. It doesn't change the prognosis or doesn't change the course of the disease process. So plan of management depends as per the criteria laid even in whatever the guidelines says, like maybe high grade disease, patient's prognostic factors, other has to be taken into account. So if this lymph nodes is negative, by means suppose this case the lymph nodes are negative. So what do you think?
Just follow.
Suppose there are multiple lymph nodes, but biopsy says it is negative. How do you explain this thing?
Reactive.
Reactive lymph nodes.
Reactive lymph node.
Sir, we will counsel the patient after nephrectomy to just follow up with the ultrasound and see the status of the lymph node. Mostly they are the reactive in nature that regresses after nephrectomy.
Okay. Why I am telling this? Is there any possibility of lymph node plus renal mass? Can you imagine or can you describe any situation like this? Possibility of midline lymph nodes and renal mass.
Lymphoma?
Yes.
Another different variant like sarcomatoid variant.
Though it is very rare, but this type of question can be asked. But as of the CT scan and the clinical features, clinical findings on table, this is a surely a nodal involvement of renal cell carcinoma. So how do you follow up this type of cases? Is the follow-up schedule is same as discussed before, or any change?
Follow up as per line of the high risk.
Can you categorize the patients like evaluation of burden of disease in terms of LDH, measurement of LDH and burden of disease, just like testicular malignancy?
Sir, we have two criteria, like I think MSKCC and IMDC criteria to categorize the patient in
Please
favorable.
be louder, please. Actually, not audible clearly.
I think, sir, there are two criteria, MSKCC and IMDC criteria.
Yes.
To categorize the patient in favorable, intermediate, and poor group. According to the hemoglobin level, LDH level, calcium more than the upper.
No, those are the criteria has already been discussed. Actually, I am not going into detail. You just tell me how your protocol of follow-up will change, or it is same for all?
No, sir, it will change. It will change in the sense of the cross-sectional imaging study will be done at the interval of 3 months.
Yeah, somebody has told that you will go for adjuvant therapy in this type of situation. So what exactly adjuvant therapy you would like to choose?
So previously we have seen the sunitinib has better response, but there is no last year we have discussed that there is no overall improvement in the overall survival of disease-free progression, DFS.
But somebody has told to go for adjuvant therapy, na?
Yes, sir.
Yes. So is it beneficial or just? Is there any recommendation to go for adjuvant therapy in locally advanced adjuvant therapy?
It's not recommended.
Yes.
Not recommended, sir.
Okay. Any of the students have any opinion to? Please tell if you want to differ.
Sir, pembrolizumab has some role, sir. It is weak recommendation in EU guidelines, sir.
Okay.
But no other, sir. TKI is no role, sir.
So nodal involvement, majority of adjuvant therapy is not useful actually. These are mainly useful in metastatic settings. So contemporary indication for performing lymph node dissection in RCC. So these are the few slides. Should I go or I just skip these things? Kalyan sir, should I elaborate or skip? Okay, grossly, the idea is to, we'll have to do lymphadenectomy as per the requirement, not to go for any extensive lymph node dissection. Usually, some lymph nodes overlying the hilum has to be dissected just to clear the artery and veins. So it is mandatory to take out the lymph nodes; those are overlying the artery and veins at the hilum. Otherwise, the radical nephrectomy cannot be done. So, but extensive lymph node dissection is not required; it's not advocated. So in 1969, Robson has started this thing, but there are many evidence that additional lymph node dissection is not done. But detecting the lymph node detection beforehand, so a number of recent studies reported that cumulative lymph node involvement rate in lymphadenectomy is around 3 to 15%. So, but whatever the data says till date or the recommendation says, complete lymph node dissection is not done. That is the only message in this case. What that I want to mention. So I am not going into detail of this presentation. So
Sumit, briefly pass the message instead of going into the details. What
Yes, sir, these are
will
all
be essential for the students to know to answer the situation? Just briefly, without going to the slides, just briefly convey the message.
Okay. So just to conclude, patients of RCC with nodal metastasis, the prognosis is not good, but there is no survival benefit or overall survival, 5 years survival is better not to go for any extensive lymph node dissection. But what exactly the hilum, if required, necessary lymph node to be removed during dissection as per the requirement. And the regarding the post-op follow-up is almost same, and there is no advantage of any TKI or any sort of adjuvant therapy. Even chemo radio is not that much effective. That's the message just I want to tell.
Yeah.
Thank you, sir.
Yeah. If I may add, actually, if you're faced with a very large T2/T3 type of tumor without any bony metastasis and with possibly nodal metastasis, you just removal of the lymph nodes is indicated only if it is supposed to. You take an intraoperative frozen section and then you see if it's a sarcomatoid type of tumor, and that sort of these very large tumors, it may make some difference in prognosis. Otherwise, I don't think the current literature supports doing a radical nephrectomy for the average T1, T2 tumors. It does not prolong survival. But I thought that's all I have to say.
Yes, sir.
So I think if that is, if we finished with that, then I think Dr. Kumar has very kindly prepared some MCQs, and I've got them on a PowerPoint here, and I'll share my screen, and Dr. Kumar can discuss the questions and give the answers. Since we just have 5 or 6 minutes, 10 minutes, so maybe each question the students can answer and Dr. Kumar can discuss. Okay, so I'm sharing my screen and bring this up.
Dr. Sarkar.
Yes.
Can you put some questions regarding the IVC thrombus and technique of removal of these such cases, which sometimes is asked in the examination? So IVC thrombus, different levels, and how to deal with it. A little bit.
Actually, Dr. Jindal is present. You are the best person with the wide experience.
Oh, no. You can just give little hints to the students, just for 1 minute or so.
I think Tarun did present on it, and I think
anyway, if it is.
Philip, আপনি বলুন না ওই level 2 thrombus the steps of level 2 thrombus management.
No, it's okay. It's okay. Because of time shortage, I'll request these candidates to go through these techniques of different, I mean, how to remove these RCC with this IVC thrombus, renal, different levels, level 1, level 2, level 3. And in some cases, even this total circulatory arrest with along with hypothermia is used in some cases in the very extreme situations where you can remove these thrombus even from the right atrium. We have done one case, but anyway, the students should go through this for so in case they are asked at the time of the examination so that they can answer. It's okay. Proceed. Dr. Kumar.
No. Yes, I think you made a very good point. I think the basic nutshell is that the level 1 thrombus you can usually manage by placing a Satinsky across the cava after dissecting the confluence. And then a level 2 thrombus, you've got to read it all up. You've got to place slings around the four left renal vein, right renal vein, infra-renal vena cava, and the suprarenal area of the vena cava. So that's the third set, and the sequence of declamping we have to know, and clamping and declamping, and then the hepatic. If you've got a level 3 thrombus, and how to deal with the inferior coronary veins as they enter the caudate lobe, and you may need help to mobilize the right lobe of the liver to deal with it. And then, as Professor Chakravarti just said, actually, you may need, the safest way I'm told by the cardiothoracic surgeons is to go for a cardiopulmonary bypass and remove an atrial thrombus, a level 4 thrombus. That may be the safest thing these days. Previously, they would take a lot of risks and hazards, but I think isn't it correct?
Yes, you are absolutely right. When case only if the thrombus is below the level of the hepatic, I mean the liver, then the things are not very difficult in the sense you can put clamps above the liver, but below the diaphragm. In that case also, this cardiopulmonary bypass may not be needed, but still better will be at least veno-venous bypass may be needed. But when the thrombus has already gone into the atrium, then you have no other choice but to go for this cardiopulmonary bypass, and then hypothermia, and then total circulatory arrest. And with the help of this cardiothoracic surgeon, they will remove these thrombus from the atrium, and from the abdominal side, you can slit open the inferior vena cava, as you have done in one case as back as 2000, in the year 2000. So you can slit open the inferior vena cava and take out the thrombus. And because this IVC thrombus and this lymph node metastasis, these are two different things. You see, lymph node, in case of lymph node involvement, prognosis is definitely very, very worse, but the same is not true for inferior vena cava thrombus. So one can try these drastic measures in such cases. Another question is asked to the students, so how to dissect, I mean, how to control this in between the vein, in between the aorta and the inferior vena cava. You may have how you dissect in the entire aortocaval region, and then you can control the vein, control the artery also from the which is coming from the aorta to the right kidney. So these questions, some of these techniques, practical operative questions may be asked the student. I will request the students to go through these chapters. Thank you.
Okay, there is a question from Dr. Jagmohan Mishra, role of angioembolization. And I think this is an important question. By and large, the textbooks say that angioembolization is not truly useful. But in a patient with a caval thrombus, especially with an arterialized caval thrombus, embolization is essential, maybe both embolization and the one important point of the surgical technique for handling caval thrombus is that you should have ideally a transesophageal Doppler to guide you. Otherwise, you cannot offer this surgery apparently very safely to the patient, because the risk is when you are going to counsel a patient for level 4 thrombus surgery.
It's 1 o'clock.
Patients may suddenly, you got to explain a 5 to 10% chance of sudden death. And if you don't have all the armamentarium and all the entire team ready, it's very difficult to handle this at any level of practice. Even at the highest center, it is very difficult. You can't explain sudden death. So, I think cardiothoracic surgeons are veering towards going for total circulatory arrest and that sort of completely safe surgery.
Yeah.
So angioembolization is definitely indicated in patients with cable thrombus, sometimes in patients with cable thrombus before surgery with an arterialized thrombus. And we have, it can be used in patients with intractable hematuria from a very large renal tumor. Intractable hematuria, sometimes it helps. And expert interventional radiologists will repeatedly angioembolize these arteries and stop bleeding. And of course, we've also used it several times for very large renal tumor. It's just, it certainly does seem to shrink the tumor immediately a bit during surgery and makes the surgery easily, but that's arguable. According to the literature, it's not widely recommended. And but in practical use, we've all I think we've all used it and found it really helpful. So
only one thing, Pulanda, I want to add: if the angioembolization is done, the intervention should be done urgently, as quick as possible, following the.
Absolutely,
within the thing they are commonly asked.
Either in the morning or the previous evening and do it the next day. But angioembolization also has its range of complications because there are so many other feeding arteries that it cannot block everything, number one. Number two, the coils may slip. I've had a patient where a coil slipped into the aorta and had to be retrieved from the femoral artery on the other side. So these sort of things you have to remember. So these are not completely, interventions are not completely safe. But I think let's proceed to the quiz now. We can be discussing renal cell cancer in great details. And Professor Dhananjay Kumar has prepared these quizzes. And I'll read the quiz and maybe the students can answer and we can, Dr. Kumar can give his comments. So according to the AUA guidelines, recommended postoperative radiographic follow-up of the chest is what is the recommendation? No imaging studies, chest radiography at 1 year, chest radiography annually for 3 years, chest radiography at 1 year, and then chest radiography annually for 2 years. So students, any answers?
Chest radiography annually for 3 years. For low risk category, like this patient is T1 N0.
So Dr. Kumar, will you comment? Please unmute yourself.
Answer is correct. Hello?
Yes.
Hello, am I audible?
Yes, you are audible.
Yeah. Ulan, relating to the previous discussion, I want to add one thing, that in our time, whenever there is a level 2 thrombus, the sir used to take the patient to cardiovascular OT and used to set up there for operation finance.
Yes.
As you have told and as you have demarcated.
Very important. This teamwork is important.
Right. So the first answer will be chest radiography annually for 3 years. That is the correct answer. Because the AUA guidelines, postoperative radiography, the chest after radical nephrectomy, T1 N0 M0. So it is not the chest radiography 1 year, no imaging studies, that is not the answer. And chest radiography, chest CT at 1 year, and then chest radiography annually for 2 years. This is not the answer also. So it is the chest radiography annually for 3 years. Next
But
question.
remember, this is for the T1, N0, M0 neoplasm.
Yeah.
It will be a bit different for a higher grade tumor. So let's
Right.
carry on. Following this is very important. Following partial nephrectomy of a solitary kidney, what is the effective method of screening for hyperfiltration nephropathy? Answer: urinary dipstick for protein, ACR ratio in the urine, iothalamate GFR measurement, serum creatinine, renal biopsy. So please come up with your answers.
ACR.
Sorry?
Albumin
ACR.
creatinine.
ACR, sir. ACR. Option
Albumin
B.
creatinine ratio.
Yeah. Dr. Kumar, your comments.
Yeah.
Please.
During exam, you have to answer fully the albumin creatinine ratio. Don't say ACR, please. So following partial nephrectomy of a solitary kidney, it is a solitary kidney and there is partial nephrectomy. So chance of hyperfiltration nephropathy is very much. And how will you effective method of screen it? Urinary dipsticks for protein. It is not the quantity, it's a qualitative one. Albumin to creatinine ratio. This is the correct answer. Serum creatinine measurement, iothalamate GFR measurement, and renal biopsy is too much. Next question.
A healthy 75-year-old man is referred after renal biopsy of a 3-centimeter centrally located renal mass. The biopsy is definite of renal oncocytoma. The other kidney is normal. The serum creatinine level is 1 milligram per 100 ml, and there is no evidence of metastatic disease. What is the next best step? Open radical nephrectomy, laparoscopic hysterectomy, percutaneous thermal ablation, partial nephrectomy, observation with follow-up imaging.
Sir, observation with follow-up renal imaging.
Yes, Ravikant, you are correct. Number one, this 75-year-old man is pretty old patient. Renal biopsy of 3 centimeter centrally located mass. Definite of renal oncocytoma. So biopsy oncocytoma. The other kidney is normal. See, serum creatinine level is also normal. And there is no evidence of metastasis. So all go in favor of just to follow up with renal imaging. That's right.
Is renal oncocytoma truly a benign tumor? According to the textbooks, some say that some behave in a malignant fashion, and sometimes there is a growth pattern to it as well. Like, some oncocytomas can grow in size. So observation
That's
is
why
very
you
important.
need follow up with imaging. That's why.
Okay. What is the commonest cause of death in patients with the VHL syndrome? Renal failure, cerebellar hemangioplasty.
Sir, now it is RCC, sir. Previously, hemangioblastoma.
They are answering before the question is over. Huh? Right? It is the RCC. It is the RCC. In VHL syndrome, it is RCC.
So putting our knowledge for the last 2 days together, these are the patients who need focal therapy for renal cell carcinoma. These are the patients who may benefit from it. What percentage of RCCs are chromophobe cell carcinomas?
3 to 5%.
3 to 5, sir.
Yes, Tanvir. Yes, it is 3 to 5%.
3 to 5%.
It's written in Campbell.
Okay. So plant cell appearance for tumor cells are associated with clear cell RCC.
Chromophobe. Chromophobe.
Chromophobe RCC.
Yes, it is chromophobe. You go through the Campbell, you'll get the answer.
Spontaneous.
The incidence of spontaneous regression of RCC. It's very important. What percentage?
Less than 1%. Point C.
5, sir.
Less than 0.5%.
Is that correct, Dhananjay?
0.3 is less than oil. It is 0.3 to 7%.
It is virtually historic.
We have seen, I think what is very rare is disappearance, but spontaneous regression, may be very, very rare, virtually very, very rare. Okay.
Hello, sir. Hello.
Yes.
Yes, sir. Sir, regarding spontaneous regression, this is the only aspect of RCC why targeted therapy has been conceptualized. So, that is the reason it is indirectly an immunomodulating disorder, immunomodulating status of the patient. So that is the reason why targeted therapy and all have been studied in detail, and now many medications have been used. This is the concept that I want to just highlight.
And in fact, this spontaneous regression, it was found in the pulmonary secondaries following radical nephrectomy. That was the original historical picture. It was the spontaneous regression of the solitary pulmonary deposit secondaries following radical nephrectomy. And from there only, this concept of immunological therapy came up. Right, you are Dr. Samir.
So, which tumors of the kidney respond best to immunotherapy protocols?
Clear cell.
Clear cell RCC.
Okay. So, which of these are not a component of paraneoplastic syndrome associated with renal cell carcinoma? Cushing's syndrome. Pancytopenia.
Pancytopenia, sir.
Absolutely. Pancytopenia.
Okay. But any of the others are also rare, but maybe not in our. Okay, we'll go to the last question. And ipsilateral adrenalectomy is indicated in cases of all radical nephrectomies, highly aggressive RCC with lymph node involvement, large upper polar RCC with enlarged adrenal, none of them. We've discussed.
Option C, sir. Large upper polar RCC.
Okay. Okay, so I think that concludes our session today. So, and this weekend session on RCC. So I will hand the. If there are no other questions, are there any other questions? If not, would Dr. Ranjan De conclude the proceedings?
Thank you very much. It's a very interesting session for the last 2 days. Last evening and today's entire effort has been given by the teachers to cover the most important aspects. Those are necessary to know, both for the day-to-day clinical practice, also for the clinical hour examination, which is coming very soon. But one thing I also want to convey, that these sessions are created for the students so that they can speak confidently in their examination. So in coming classes, I have the request to the students, those who will be participating, to speak. This is the trial stage for you to practice for your examination. If you cannot express yourself confidently in this forum, it will be very difficult for you to participate properly in the conversation during your examination. So I have seen few of the students are doing well, but many of them requires a lot of improvement in their communication skill, which is very important both for the examination, also for day-to-day practice in future. With this, I must thank all the faculty, including moderator and our senior teachers, Dr. Dhananjay Kumar, Dr. Sudeep Chakravarti, and Kullan Sharkar, and also the students for participating and making the program very, very successful. And hope in the coming the classes will also be very attractive like this. I have a small announcement to make that the next weekend that there will be no class on Saturday. It will be held on Sunday morning and Monday evening, and accordingly information will be conveyed, just because we have received a lot of requests because of the Bengali New Year's and the Bihu program in different parts of our zone. So next weekend class will be on Sunday morning as usual, and also on 16th and 17th evening from 6:37. With this, I conclude today's session. Thank you once again to all my students and my senior.
Thank you, Ranjan. Thank you.
Thank you.
Thank you all the office staff.
Thank you, Pullan.
Yes.
Thank you to the office staff.
Thanks everybody.
Thanks, Sudeep. Thanks,
Thank
Sudeep.
you. Thank
Thank
you.
you.
Yes.
Thank you.
So, hope you all the best. Thank you.
Bye bye.
Okay, bye.
Bye bye.
Bye.
Bye. Bye.